Terrific. We will we'll do some introductions. I think that's always nice to do, and we do have 3 folks on the phone. So, Victor, can we open it up on the phone and ask them to introduce themselves? Mark Fairbanks, are you there?
Let me see. You may not have called in yet.
Joe Finkbonner, can you hear me?
I can. I'm here. Thanks, Dan.
Yeah, welcome. Glad you made it. We appreciate the extra effort for those who are balancing multiple commitments. And we have Marie on the phone as well.
Yes, I'm here. Hello, everyone.
Terrific. And I believe Mark Fairbanks from the state is going to join us at some point, so we'll welcome him when he joins us. Let's start to my left with Claire, and we'll just do clockwise and do some quick introductions.
Hi, I'm Claire Trinquez. I'm from the Oregon Primary Care Association.
Jesse O'Brien with Osprey.
Ken Preventer with Pacific Source.
Sean McNulty with Project Access Now.
Jim Hauser, Hawthorne Auto Clinic.
Pat Allen, Department of Consumer and Business Services.
Shannon Saldivar from Revoco Insurance.
Laura Callie, also Department of Consumer and Business Services.
Cindy Condon, Condon Family Consumer.
Shauna Butler, Tomlin Benefit Planning.
Barry Leslie with the Marketplace, part of the Department of Consumer and Business Services.
Dawn Jagger, part of the Marketplace as well.
And Victor Garcia, part of the Marketplace as well.
And Deanne Gilmore with the Marketplace.
And I'm Dan Field with Kaiser Permanente. And I don't think we'll do introductions, but I do want to welcome people. We have some other state staff here. We have some members of the public who we might even hear from later, I'm thinking. But I just want to welcome everybody, and we appreciate your time and energy joining us here. In a minute, I'm going to go through the agenda and just give people a sense. We have actually some big stuff today, and we have a pretty packed agenda, and it's we have a process we're going to try and stick to. Before I do that, there is an 800-pound elephant in the room, and we've asked Pat Allen to just maybe spend a few minutes responding to that and framing our work in the context of the day after the election.
Sure, thanks, Dan, and I'll just take a minute and basically share a message that I shared this morning with our Marketplace staff and then more widely with staff in the department. And sort of the simplest version of the message is, let's just all take a deep breath and step back for a second. There's kind of three pieces to that. First, nothing today is different than it was yesterday in terms of our programs and what we do and what we're focused on. At the Marketplace, staff is focused very, very directly on getting people signed up for health insurance policies, which will go into effect on January 1st. And the best thing that our staff can do, and I think the best thing that we can do as an advisory committee, is stay focused on the task at hand and not get terribly wound up today on our fears about what might happen in the future. Which kind of gets you to the second thing, which is it's really easy in a circumstance like this to take all of the rhetoric you hear in any election campaign and fill it up with your worst imaginings of what that must mean and what it'll look like when it gets implemented and all those sorts of things. And usually that's a mistake, because usually, this will shock you, I know, but politicians don't do in practice what they said they would do during a campaign. Now that varies a lot with the politician and the campaign and the revenue and all those kinds of things. But one small example you'll be familiar with, there's been the rhetoric about repealing the Affordable Care Act. Well, at the same time, and for some people that means get rid of the tax credits and penalties and all of the financial components. At the same time, some of the same candidates have said, but let's keep things like guaranteed issue. Well, you really can't have those two things live in the same space, and people are actually going to sit around tables in Washington and have those conversations and figure that out, and there'll be some kind of a coherent policy that gets put together. It'll probably be a different policy than decision makers here in Oregon might make, or that the decision makers previously have made, but it'll hang together in some fashion. And so I think we need to let that process work itself out before we start doing all kinds of terrible imaginings of what the worst could be. That's not to say we don't contingency plan and don't think ahead about what we need to be prepared for, but again, it's back to the theme of taking a deep breath. The last thing is to make sure that people understand that and this was kind of a broad message within our agency where we regulate, depository institutions along with the federal government, and where we regulate worker safety by a grant of authority from the U.S. Department of Labor, and a bunch of stuff where there are questions about what's going to happen going forward. In all of those areas and in the Affordable Care Act, most of the key features of what we do also live in state law and will continue to live in state law even if federal law changes. Now, there's a lot of complexity that goes with that in terms of how you have to respond and what might need to change in state law or those kinds of things. But Oregon was doing health insurance and health care reform for a long time before there was an Affordable Care Act. And among other things in the results of the election yesterday, there was not some sea change in political philosophy in Salem, so I would expect we're going to continue to want to be at the forefront of doing health insurance and health care reform in the state. And so I think we'll figure out a way to muddle through this. And again, back to the initial message, just take a deep breath. We don't need to panic. And in particular, today we got some stuff that you look at and you think, well, why would we spend any time on that? Because that's a non-starter. Let's go ahead and give the work that we've got in front of us I think the respect and time it's due, and let's allow some time for some things to shake out and see what's going to happen.
Thank you, Pat. And I would just turn to the Vice Chair, Jesse. Do you have anything to add to that? And ask Laura or Barry from their positions in the department if they have anything to add, and then we'll move on.
I think Pat basically covered everything I would want to say as well. I mean, I think we shouldn't kid ourselves that the policy environment federally we shouldn't just assume that we can go ahead with whatever we want to do at the state level. There will be some challenges with any of the stuff that we're about to be talking about. But yeah, let's give the work its due, and there's certainly no lack of work to be done in this space, even if everything we've done today disappears. We'll just figure out a way to muddle through.
And we know for sure we have a 2017 marketplace to run and make successful and give that our best effort. So nothing, even in worst case scenario, that's not going to change. Barry or Laura, for that matter, anybody else have any concerns just on that issue in the context of our agenda? Because if not, what we'll do is we'll talk about the agenda and then we'll dive into our work.
Yeah. Well, now that's all I have to say. Yeah, that's our focus. As Pat said, we're just going to keep moving forward. So
terrific.
I'll make my comments when I go through the matrix.
So we have two major issues that we're going to talk about today. We're going to talk about the marketplace stability matrix that Laura will present on. This is a series of ideas and strategies to stabilize the marketplace. And as Laura will describe, it's a product of many hours of work and thought, and we're very excited to bring that here today and get folks acquainted with it and give you an initial chance to ask some questions, present some early perspectives on that. Then we will move to our second major agenda item, which is a review of the Wakely report on the basic health plan and the staff response to that. And what we'll do at that point is we'll just allow the staff to give us a presentation. We can ask clarifying questions. Immediately after that, I'd like to move to public input and comment on the basic health plan report and the staff response. We will then close the public comment period, and we will move to our committee discussion and decision. And at that point, it will just be the committee. We will have a really robust discussion. Welcome, Joe. And I want to just point out, it's a couple hours down the road, but when we do get to that point, I want to clarify that we will need to arrive at a very specific recommendation. The legislature asked us formally to make an assessment and make a recommendation. So at the conclusion of that discussion, the plan is to have a motion, and then we will vote on that motion. And I want to just recognize ahead of time there may be strong differences of opinion, and we may have a split vote, perhaps not, but I want to just prepare people for that. That said, I think we'll have a very robust discussion. We'll have a motion, we'll have a vote, and then our work will continue. So any questions, concerns about the agenda as I've laid it out, or should we dive into our work? Okay, excellent. And again, welcome everybody here, and I thank you. Hopefully the room won't get too hot as we're going on.
It's warm in here.
No windows allowed.
Yeah. Okay, with that, let's dive in, Laura, to our first agenda item, and you want us to be looking at.
Oh, I didn't look through the package. It's
We do
Looks
have.
like this.
yes, it looks.
And I'd like to
Building
tee it up.
a state-
Sure,
quickly.
Pat, please go ahead.
This work is born out of experience at the department largely over the past summer, where we experienced a lot of instability in the individual market and a lot of instability in a variety of ways. As a result of that, we, together with the governor's office and the Oregon Health Authority and some informal stakeholders, got together and spent some time over the last 3 months or so really thinking, what could we do in the absence of federal action to try to stabilize the market? As we went through that conversation, I think it broadened into not quite complete absence of action at the federal level, and now includes some things that would require waivers and sometimes more. But the idea is to stabilize the market. We think of stabilizing the market in 3 key ways: stabilizing the cost of insurance for individuals, providing financial stability for carriers, and then assuring that we've got geographic stability in the offerings, that Oregonians across the state have access to multiple providers. We started with 13 providers, almost all of which were statewide. We're not suggesting that's what geographic stability is, but it's probably more than one carrier across the state. So what you'll see is a package of suggestions. It's not an entire package that's sort of a do the whole thing or not, but neither is it a bunch of individual things that are sort of a la carte. You'll find as Laura goes through these that there are some clusters of concepts that if you want to go down a path, there's a group of them that you would tend to want to do as a part of that. So with that as background for what this is about, I'll turn it over to Laura.
Great, thanks, Pat, and thanks for having me back here with you. This is 2 meetings in a row. I think I get to come and be with the Marketplace Advisory Committee, so it's great to be here. I think kind of teeing off of what Pat had just laid out, it's easy probably to think, okay, well, the world may be changing, so is it relevant to think about these things? And I think to help you understand the premise that we've worked with is that we've made a lot of progress at the federal level in terms of expanding access to health coverage and health care. But there are some things that still need to be worked out, and some instability that we've observed, and we've not been, I'd say, very optimistic about a swift solution at the federal level. And so we've said, okay, what can we do at the state level? And while the nature of what we may be able to do at the state level may change to a degree, I think actually the uncertainty that we're in right now probably just underscores the need for us to be thinking about if delivering access to health care and health coverage for our state is really important to us, then we should be thinking about what can we achieve at the state level. And so I think, of course, looking at this through the context of we've developed these concepts, we didn't just kind of wake up and do these this morning. So as we start as we continue to talk about them and think about what is, I'd say, most useful, what is most feasible, that may adjust and shift over time. But we've really, I think, starting with that premise of we have I think, demonstrated commitment as a state to wanting to continue to move this forward. So what I'm going to do is, you've got the matrix in front of you. I'm going to hop around just a tiny bit, because the way that I think it's helpful to think about this is that we've got many different concepts that could work together as a package, but some of them are really kind of more aimed at solving certain of the, I'd say, the issues that we see in the market. So I'm going to start first with this idea of how can we get more stability into the market as a whole and more, I'd say, more equitably spread the risk across the market. And there are a couple of different ways that we talked about doing that. The first of these is looking at reestablishing and expanding a state reinsurance pool. So for those who aren't as familiar, we have a federal reinsurance plan that actually sunsets at the end of this year. We also stood up a state reinsurance plan that wraps around. The federal plan also ends at the end of this year, and the idea was to help kind of phase in as we work through the first few years of uncertainty in implementing parts of the ACA, and it would help to stabilize premiums and kind of reduce the premiums that the individual market paid. And so here we'd be looking at reestablishing the state program, but really broadening it to look more like what exists at the federal level, where you're assessing the broad health insurance market, not just individual market business, in order to help bring down and stabilize rates in the individual market.
can you just, for the benefit of all of us, just double click on your statement about we currently have state and federal, they're coming to an end. Just refresh us that those were the 3-year, they're always designed to transition
They
out.
were, yeah. So you probably heard about the 3 R's. So they were risk stabilization programs in the individual and also to some degree in the small group market. And so you had reinsurance, risk adjustment, and risk corridor. Reinsurance was meant to help cover high-cost claims and help more equitably spread the risk of high-cost enrollees across the market. And it was just focused on the individual market on a national basis. You have risk adjustment, and reinsurance is a temporary program. I'll come back to that in a second. Risk adjustment is a permanent program and is actually meant to look at within each state and each market. So the Oregon individual market is one market on its own, and you also have the Oregon small group market that's looked at on its own. How can we make sure that through guaranteed issue and all these other elements of the ACA that no one carrier is getting, I'd say, a riskier than average population, and that sharing that across the market. And then the third is risk corridor, which was intended to kind of help guard against basically difficulty in pricing in a period of significant uncertainty. And there have been a number of challenges with risk corridor, but that is also a 3-year program that is ending at the end of this year. Reinsurance was always designed to, along with risk corridor, be a temporary program to kind of help acclimate and get through some uncertainty as the market stabilized. With reinsurance, both at the federal level and the state level, it was a deliberate decision to kind of start at a higher level of benefit to kind of have more stability in the first year and then taper it off as we got to the end of the third year. So we're in this last year where the effect of those programs, both at the state and the federal level, are much smaller than they were in 2014. But the idea here would be looking at, I'd say, restoring that to having more benefit, because right now, if we do nothing, it just goes away for 2017. Well, it probably already, right now, that's what the rates reflect, is that those go away. So that is one, I'd say, key idea, and I think, just to be clear, as we start thinking about kind of things that require kind of revenue, we know that those are things we'll probably have to continue to talk about as we think about the way forward.
It looks like we've tried to stay away from pricing these, but it's good that you're calling out that there is a price tag associated with this. And as you note there in the first bullet, it would be funded presumably by an assessment across the market.
Which is consistent with how it's done today.
A quick question on that.
Yeah.
One state that I know has recently taken action on this is Alaska, and they did the kind of interesting thing of funding it with an assessment on all lines of insurance, including property insurance, life insurance, and so forth, which creates a bigger pool and a smaller assessment on each company. Is that something we've considered?
I don't know that we've explicitly considered it, but it could be on the table, I suppose. And I mean, in terms of, as we start thinking about all the different solutions we need to think about, the other thing I've heard discussed, I don't know how feasible it might be, but there's also been some talk of if you're able to set up a reinsurance program that reduces the need for tax credits that would basically be needed in the absence of a reinsurance program, is there an ability to actually seek a waiver to assist with that? I mean, I think that is an open question and something to think about as well. Any other thoughts or questions about reinsurance? Does that make sense, at least kind of conceptually? And I should mention, all of these are kind of, I'd say, at the 10,000 foot level and trying to kind of at least kind of scope out what we're thinking about conceptually, but there'll need to be a lot more work with you all, with other stakeholders about how exactly this would look.
Laura, I do have one question on this. As your actuaries have reviewed the filings of the health plans over the last couple of years, is it possible for you to identify the impact that reinsurance has had on rates? Has it been positive, and if so, to what extent?
I don't have those numbers top of mind, but we certainly go through rate review in terms of kind of thinking prospectively about what the impact we expect to have on rates versus what really was the impact in terms of dollars that went to carriers to pay for claims. We have that data, and it has, certainly in the earlier years, we were talking about double-digit impact on reducing claims and premiums. And so it all depends on how much money is being raised through an assessment to drive at this problem. But it's actually, I'd say, a relatively straightforward calculation for us to say, if we want to be able to, we think claims costs are going to be a certain amount in the aggregate and premiums are going to be something kind of a little higher than that, and we want to throw a certain amount of money at that problem, what's the percentage reduction, and then correspondingly what's the percentage assessment that needs to be levied.
Do we want to talk about the back of the napkin numbers we looked at last week on that?
I think they're still kind of preliminarily, but I mean, I think if I think about it, in the past, I think we had looked at maybe 1% premium assessment and kind of giving you maybe something around a 4 to 5% reduction for every 1%. And we should kind of tighten that up. But I mean, that's one look at it.
Right.
It all depends on the assessment base as well.
Just as you're closing this out, if I could just ask you to clarify, the effect here, it doesn't reduce the cost of the claims. What it really does is kind of
spreads the risk.
Spreads the risk.
Right. And it spreads it beyond the individual market. I think that's the key. Is it basically is spreading it to, we'd be looking at spreading it to small group, large group, and self-insured, which is consistent
so going
with how we do
back
it now.
to the points that Pat was making, this would address the criteria related to presumably geographic access, for example, because a carrier that might otherwise say I can't do that would be inclined with, they would be inclined to jump in. So I just want to tie it back to those principles of how reinsurance would help stabilize the market.
Right, and as you can see on the matrix too, we tried to kind of look at, we phrased it in kind of a shorthand, but we looked at what are the problems we're trying to solve, and you can see individual market stability, availability, access, and cost and quality.
It's probably worth noting, Dan, that the original state reinsurance program was targeted to a specific population, so it was not a broad vehicle, I think, as this would be. The federal data would give us the data we need, but the state program was, we targeted people coming out of Oregon Medical Insurance Program, the high-risk program, the Children's Reinsurance Program, portability.
Yeah, it was pretty narrow.
Yeah, good reminder, Ken.
And we had to know who they were to be able to follow them through and all that good stuff.
Yeah, I think we were kind of, I think this is envisioning something a little less complicated and also a little bit more broad-based, but
it offers the tactical advantage of being existing law, which involves removing a sunset rather than creating something new, and it's an existing assessment. So it's got some positive features on that.
Just a really quick point of order here. I assume we're just going to go through all of these on an informational basis right now. So we're not going to be debating them on the merits just yet.
And I was just going to say, this will probably take the longest. It's an existing program people are familiar with. Some of the others we'll just go through pretty quickly.
Yeah, and I can kind of try to run through. So I have until 2 o'clock, right? And do you want to actually? Does that include discussion of this? And I can try to.
But to Jesse's point, I think it's we're out basically kind of socializing this now. At some point in the future, before session, we're likely to want to come back to you with probably a somewhat narrowed down or somewhat different list and ask for a recommendation.
Well, I'll keep buzzing through then if that's all right. And please stop me if you have questions. I'll try to make sure that I'm clarifying it as much as we've, I'd say, thought it out. But some of these are still, I'd say, at a conceptual level. So staying with this concept of how are we helping to, I'd say, increase stability and more spread the risk. You'll see there's a little bit that starts to get into statewide availability and access as well. The next concept to talk about is this concept of a pool of last resort in geographic areas that have limited choice. And so it's really, as I think you've heard a lot about earlier this year, we had some parts of the state that were facing significant reduction in the number of options available to consumers, and we were able to bring back some of those options, but really highlighted the need to have a mechanism to deal with really the absence of options. And so this would be an idea where there'd be some sort of a measure of determining whether a part of the state didn't have enough options. So basically deeming a part of the state non-competitive from an insurance market standpoint, and probably have a lot of conversation about what those criteria look like. But that if we deemed an area to be non-competitive and need more options, that we would set up this pool of last resort. That's basically a stand-up, something that looks like a carrier where people in that part of the state can pay their premiums, have their claims reimbursed, and they would have access to providers through that mechanism. But the key here is also that any insurance mechanism, yes, paying premiums is an important way to cover costs, but you need a way to make sure that you're absorbing potential risk. And all the insurance companies are required to hold capital on hand. And so this would also require that all of the carriers have a responsibility to absorbing that excess risk that would normally be covered by by capital and surplus. And so it'd be kind of, I'd say, blending a bit of the reinsurance concept with this idea of needing to set up an entity that can service people who don't have options. And so, this is a pretty all right. Support from the dog on the phone. That's usually. This is actually, I'd say, a relatively common solution in other insurance markets where you've had issues in terms of not having I'd say broad availability to all who need it. So, for those who may or may not know, I come from the non-health insurance side of the world originally, and so things like workers' compensation, auto liability, basically mandatory coverages where there is underwriting actually today, there is a mechanism to deal with people who can't, who actually don't have access to coverage. So this is a little bit of a spin on that, where you're looking at how do we make sure that everybody who is entitled to coverage has a way to get it. We fleshed out in here an idea. It doesn't necessarily need to be the only way that it could work, but one question we had is, okay, you stand this up, how do you actually have provider contracts in order for people to go to the doctor? And so one idea that I think also needs more discussion is, could you use the CCOs in a way to leverage those relationships? One of the other important pieces of this is that it really would need to be, I'd say, assuming that all of these pieces stay in place, in order to allow people to continue to access tax credits, there would need to be a mechanism to make sure that it can offer qualified health plans. So it's important that it really look like a commercial option for people.
Questions about this one in particular? This is a great opportunity, as Jesse noted, for us just to ask some questions, make sure we understand at the 30,000 foot level. Okay.
All right, I'll keep moving on. And if you think of questions down the line, I'm happy to answer them later on too. So I might spend a little more time on some of the more, I'd say, detailed ones, and some of them are a little easier to understand. So the next one is actually looking at something Dan kind of alluded to, is how do you, I'd say, incentivize carriers to participate in different markets across the state. And so this idea would really look at tying business that has kind of been more profitable and been, really been more stable to the individual market, and saying that if you are a carrier that has any of the four following types of business, that you would be required to offer individual market coverage on the marketplace. And so we were looking at if a carrier has a contract with PEB, so the statewide employees, a contract with OEBS, the state teachers contract, Oregon large group fully insured plans, or Oregon small group fully insured plans. And so the idea there would be, if you are offering plans in any of those four areas, that you would be obligated to also offer individual market plans on the marketplace in the service areas in which you are offering those other plans. And so it would basically prevent a carrier from saying, I'm going to be in these parts of the states for these markets, but only in this part of the state for the individual market.
And we're obviously not going to name names, but we do think there are carriers right now who are active in bidding or securing PEB and OEB, and who are not necessarily offering QHBs.
That I think that is true, and I mean, certainly we see that there are carriers that have different service areas for different product lines. So that's absolutely happening today. And I think that, one of the things we haven't kind of talked about explicitly, I think we may have talked about it at the last meeting, about some of the, I'd say, the challenges of guaranteed issue is it's left fewer tools for a carrier to be able to manage exposure and manage risk, and so that's been part of what's happened as a result of that.
And this would require a carrier that had an individual market plan to also participate in the marketplace.
Correct.
Right?
Correct. This would basically say the marketplace is the individual market. There's not an off-marketplace option. It's basically the way that this would work as well. So, any other questions about this one? All right. So I'm going to actually skip on your matrix and then skip down a little bit, but it kind of stays in this theme of spreading the risk and kind of market stability. So the next one is kind of down at the bottom of that first page, which is looking at a cap for enrollment for non-financial solvency reasons. And it's not just as simple as for non-financial solvency reasons, but just to give you guys some context, right now, if a carrier, carrier has a certain amount of capital and surplus available to it, there's probably a corresponding amount of premium that is, I'd say, prudent and safe and sound for the carrier to be able to service without threatening the solvency of the company. And so actually I didn't mention this at the beginning, but I think most people know. I mean, my role at DCBS is regulating the overall stability of the insurance and financial markets, and so a big piece of our consumer protection work is solvency and ability to pay claims. And so, there's absolutely a need to make sure that enrollment doesn't grow at a pace that threatens the solvency of a carrier. I mean, that's not really in the best interest of consumers. But one of the challenges that we've run into under the ACA and the guaranteed availability requirements is that you essentially have to have a carrier that's on the brink of a financial solvency crisis to be able to trigger a cap. And that doesn't really allow for, I'd say, proactive consumer protection from our perspective as a regulator. And beyond just financial capacity, there are other issues as well. We've talked already a lot of the years over network adequacy, about operational constraints, and I think that we think it would be helpful from a stability standpoint across the market to have more and appropriately regulated ways for carriers to manage their enrollment in a way that is fair and equitable to the market as a whole and to the consumers.
So Laura, right now it's all or nothing. A carrier either tells you in the marketplace we want to be in this county or not. And this would allow.
And there are some ways. So if you get to a place where it's, it's really like we know as a regulator that they would be falling below all sorts of regulatory benchmarks, and that we would actually be required or to take action. There is a way for us to say no more enrollment, but it's a pretty severe step. I mean, the tool that we have is, it's really a drastic and a very public step, and that's the other piece too is. We've always kind of looked at this. If you proactively say, carrier A has a cap of 10,000 enrollees, are you sending a message that that's not a carrier you should buy your insurance with? Which is not necessarily the message we would intend to send. Which is, there is a reasonable amount of exposure that any one business can take on to operate safely, and so that's been one of the challenges: is how do you address that issue without actually causing unnecessary fear among the public? And so that's been another element of it too. I should note that Minnesota has actually very publicly talked about this issue, and they are the first, that I'm aware, first state who has defined enrollment caps for each of their carriers and publicly announced them before open enrollment. So there are probably two pieces that we need to look at here, which is, I think, the logistical ability to do this in terms of what does the technology allows to do and how quickly. And then how do we deal with the guaranteed availability requirements? And so since Minnesota is subject to those as well, they do have their own technology. We're also interested to learn from Minnesota kind of how they approach this so that we can learn from them.
Dan, one of the states we're in has tried to apply a cap to one of the plans, and through the federal marketplace it's not possible to do that with a number. So they actually talked about using a date, which actually creates potentially big selection issues when you think about who enrolls early versus who enrolls at the last minute.
And there still are, I think, a lot of those questions to answer is how do you operationalize a cap on enrollment, and what do you do if a cap is below what a carrier currently has? I mean, there are a lot of different questions I think to answer in terms of, how can you fairly apply a cap? How can you actually shrink membership if that's what needs to happen? I mean, I think there are a lot of details to work out on this. But
the Minnesota example, as I read it, looked like a risk minimizing tool, because if I remember correctly, each carrier's cap was above its current enrollment, and collectively the caps added to more than the entire market enrollment. So it wasn't a means of trying to drive anybody down. It was to say you're in, and you're only going to go this high, and you can price and manage your risk for that maximum exposure, versus our model right now, where unless you price yourself out, you're basically exposing yourself to all 130,000 individuals in the individual market.
And Medicaid does do this, I think, in Oregon. My experience with our Medicaid plan is they've allowed us by the county to say this is what our network will allow us to do, and some of you in the room may be familiar with that. So it's not an unusual concept in Oregon. We just haven't applied it in the context of the commercial market.
And my biggest question about this, which I've already posed to Laura, but I might as well say it more publicly also, is how do we set this up so it doesn't create a situation where consumers don't have an option at all? And in the case of Medicaid, when enrollment is capped, you can just go on open card fee for service, and then there isn't an option like that in the commercial market. And if all of the caps add up to more people than there are in that part of the state, then it's probably fine. But what if there's only one carrier and you have to cap the enrollment? Maybe the pool of last resort solves the problem, but it could be a tricky problem.
But that does get to the fact that some of these work better as a cluster of multiple options than any one kind of a silver bullet.
Good point.
All right, shall I continue? Okay. So now I'm going to kind of shift gears in terms of, we've talked about things that are looking at market stability, and now I think there are a couple of options that really start to talk to incentives and things that actually are going to maybe drive market dynamics. And so I'm going to stay on that first page there and talk about reducing the grace period from 90 days to 30 days. And so I think that most of you are probably familiar with this, but right now there is, for marketplace plans, there is a 90-day grace period once you've effectuated coverage to be able to pay your premium before your policy is termed. And off of the marketplace, that's a 30-day period. And so there has been a lot of discussion about whether, especially as we get toward the end of the year, does the 90-day grace period actually drive some adverse selection where consumers may wait to see if they actually have a need to pay their premiums to keep their coverage? I think one of the challenges is I have not yet, and I've not yet seen data, I'd say, to support that this is actually happening or that this is the cause of it. And I think that this has been a national discussion, and I am not aware of any data in other states as well. But I think one of the things, as we've talked about, is how can we make sure that as we're thinking about this package of ideas that there's something really kind of that's bringing everybody to the table to kind of have responsibility to help make this work well, I think is one piece of it. And then also really looking at a combination of not creating disparities between our on and off exchange markets in terms of incentives for consumer behavior. And then the other piece is really, I'd say, thinking truly, is a 90-day period necessary? Should it be a 30-day period? Is there somewhere in between that makes more sense? And I think that we do recognize that if there is a reduction that in the grace period, that there probably need to be a need to talk about exemptions for certain hardships and that sort of thing to make sure that this isn't actually harming someone who, through no fault of their own, isn't able to pay their premium. But this is an idea to try to help with a little bit more stability and make sure that people are actually in and paying for their coverage regardless of whether they're getting sick or not.
I have a sort of simple question around this. If they do lose their coverage, and are they allowed to actually re-enroll, or is it because it's a loss of insurance? But
I don't think for non-payment
entirely.
Non-payment is not.
Non-payment
Validates it.
That's what I thought. So that concerns me that there isn't another option as well.
Well, but I think that's kind of part of the point. Is not. So the issue is how do you through these things, but I mean, there's a whole host of other issues we need to deal with. How do you help people see and really, I'd say, experience the value of having insurance? And I think that's become more complicated as rates have increased, deductibles and cost sharing have increased, and the hard part is that I think that it's easy to say, yes, you should buy insurance, it's good for you, but it's even people who see the value are having a hard time, I think, finding the way to be able to pay for it. But I think it's a combination of trying to find a way to make it more affordable, but also to help reinforce for people that the value of insurance isn't just having it when you get sick or when you know you're going to get sick. It's helping protect you, your family, the financial future of your family, and that's, I think, the harder piece of this. And I think by one of the challenges is by letting people kind of jump off and on throughout the year, that erodes, I think, the ability to kind of make sure that we've got a pool of people who are in and consistently, sharing in the risk and paying in good times and in bad.
So I just want to pause and ask how this is resonating with those of you who work with individuals throughout the year enrolling. How this does this seem like a hardship? Does this seem reasonable? Does it? We're just asking for high-level impressions, not a commitment.
I'll jump in.
Yeah.
So it has been my experience that even with the 90-day grace period, people are having hard times paying their premium, or they'll pay a portion of it, and then the accounting and the bookkeeping, they think that they're paying it. So another part of the problem is if you make changes to your income, then your premium is likely to go up or down depending on what that change is. When that change happens, then the person has to remember what, they get an invoice or something like that from the insurance company. But if you don't open your mail, and I hear more and more people say they're not opening their mail because they're more online kind of people, you haven't paid enough of the premium, for example. That's usually the example I hear. So you think you're safe, and then you find out you've been let go. I had one just recently have that happen to them.
I'd say the same. I see sometimes the carriers take time to process changes that have been done through healthcare.gov, and so you have this kind of retro premium that's just been building, and sometimes it takes more than 90 days for the consumer to get it, but it's retro, so that it can be challenging for consumers. I've also seen consumers who have ran into that 90-day extension and not pay their bill, not realizing their policies were going to cancel retro 90 days, and then end up with huge claims that they're on the line for. Providers have had to go back and rebill everything. So, I think potentially shortening it would be a little bit better to make things more consistent on and off, but with that, make the federal marketplace and the carriers work a little bit better together so consumers aren't waiting sometimes 90 plus days to receive changes that they've made and then billing that they've seen to. So.
That's helpful
feedback.
feedback.
It is
This is
helpful.
new insights for me.
Because I think from our perspective, we don't want this to basically come across as removing a consumer protection, because I know that's part of this piece is making sure people have time to be able to make their payments, but I think we also want to make sure that we're guarding against the unintended consequences, but making sure that we're also, I'd say, placing appropriate weight on how frequently how frequently is it actually challenging for someone to know exactly what they need to pay when these changes come through, and their ability to get that done in the right period of time versus how often people are taking advantage of the 90-day period. It's hard to know, I'd say what that math is squaring to.
Quick.
Hi, this is Maria on the phone. If I can just jump in for a second.
Yeah, go ahead, Maria.
Thank you. Yeah, so I agree with some of the things that have been said, and I think a middle ground in that maybe a 60-day grace period would be helpful. But I think what would also help is just more education around that grace period and more information and education about making sure that you pay your premium so that you don't, if possible, so that you don't run into those, backdated claims and things like that. But I agree with the concept, and I think it's a good strategy.
Thank you, Mary. One last comment, I think, from Jess, and then we'll keep going.
Really quick question, not on the merits of this, but is this something that the state can just decide to do, or do we?
It will require a change in federal law. So that is the 90-day period is in federal law, and I have heard that there is some. Who knows what's happening, but I've heard that there's appetite to actually revisit this. I think on a bipartisan basis. I've heard that already. And actually, to the comment that Maria made, actually not going necessarily to 30 days, but looking at something kind of in between 45 or 60 or something like that. So I don't know whether this could be among, whatever kind of package of changes could be coming. But some of these we did recognize, I think Pat mentioned this, that might require a waiver, might require federal changes. But there is another piece of this, which was especially, prior to yesterday, thinking about if there were things that we knew might be on the horizon, we wanted to be able as a state to act on them and basically move on them ASAP. And that'll actually come up when we talk about the next one too. So
go for it.
Okay. So the next one is the one right below it on the matrix, which is looking at a way to allow employers to make a defined contribution to an HSA or an HRA that would allow consumers to buy, or employees. So this is traditionally in the group market, to be able to buy individual market plans. And so the idea here would be, this is maybe employers who are, maybe would prefer to kind of give their employees more options and not necessarily decide on one or two, or maybe finding it difficult to be able to actually secure, affordable coverage through the group market, and they would like to kind of allow their, contribute somehow and allow their employees to make those decisions for themselves, or allow an employee to make a decision for him or herself and their family that's consistent if they can't offer dependent coverage. So, I think there are a number of different flexibilities that this might afford, and this is one that, again, I think there's been a lot of interest on both sides of the aisle at Congress to do something about. So I think actually even our president-elect talked about kind of looking at ways to deal with HRAs and that sort of thing. So who knows, this one might be moving in like some way, shape, or form. So this would be an example of something that requires a congressional change that we would then need to be kind of ready to react to.
To piggyback on.
Correct.
Good.
I have just a quick question on that, and it might not really relate to it, but I think, Jim, you had sent some articles about SHOP, kind of gutting SHOP. And could these go hand in hand? I mean, does that help the small bit? If SHOP is gutted, then is this a logical step from there? I might have misread the
As an alternative,
article.
yeah.
Right.
Another tool for small businesses.
Right. Well, and I mean, it sounds like SHOP would go away, really. And so, what other tool is there?
Well, I think what's happening is CMS is evaluating whether or not there will continue to be a requirement for SHOP. They gave states additional time to evaluate whether or not they want to implement SHOP, especially as we look at kind of the effectiveness of SHOP nationally.
Mm-hmm.
And so I think what this does is kind of different than SHOP, but it is the same in that it provides additional tools for small businesses to think about in terms of affordability and access to health insurance for their employees. So it's in the small business realm, but I don't know that it's necessarily associated with SHOP.
Right. I don't think it. I mean, I wasn't suggesting that it was associated with it. I'm only suggesting that it sounded to me, or it read like SHOP if they do away with the tax credits. I may have read it wrong. That program's kind of gutted without it. And so, if we did something like this, does it give not a replacement for it, but it's something for a small business to say, then I'll do this.
So I'm not completely familiar with HSAs directly, not that I've used them, but my understanding is that they are notoriously insufficient, inadequate, and lead to people assuming they have coverage or they're sufficiently protected when they're not, and lead to bankruptcies and medical bankruptcies and stuff like that. That's what I would want to more protect against.
I don't know if I know much about kind of that endpoint. I mean, I think a lot of people use an HSA as a tool to kind of help set aside money on a pre-tax basis to pay for cost sharing under deductibles and that sort of thing.
Uh-huh.
But part of the idea here was for the money to flow through an HSA pay for
premiums as well.
That's
Exactly.
That's the main change.
That is a little bit different too. But I think as HSAs currently exist, I think it's more that model of helping give tax tax altering out-of-pocket costs.
And they benefit high deductible plans. Currently, my employer offers a high deductible plan with an HSA. Next year, we're moving to an HRA. But there's pluses and minuses certainly with it.
But just to be clear, Laura, the barrier that exists now is that employer dollars should not be used in the individual market. So I don't mean to cut off the HSA discussion. It's helpful. And in fact,
it's an IRS rule, I believe.
Yeah,
right, exactly.
This is not even like a health reform. Right. This is actually kind of
whether it's taxable income.
Yeah, this is one to probably watch for unintended consequences. This
could
cause some weird behavior in the market. It is important to note, just maybe employers making options not quite the way you would like them to do in a functioning marketplace. It may provide some weird incentives that you don't expect. I would say, if you go to the SHOP discussion and just connect that, the issue around SHOP is one, the utilization of SHOP nationally is low, and two, the utilization of tax credits is really low. Tax credits existed pre-ACA, and it hasn't changed. I mean, it's about the same level pre-ACA and post-ACA, so that vehicle has not. I mean, I think there's committees that have gotten together over and over again trying to figure out how to boost it and haven't been able to figure that out.
One thing to mention, because Ken, you just brought up there might be some unintended consequences here. I think with any of these, if you see either particular features that you think we should be thinking about or unintended consequences that we should be kind of exploring or worrying about, let us know. Or if you see something glaringly missing from this list, I mean, we definitely want to hear from you as well. I mean, we're really trying to socialize this, as Pat said, just to make sure that we're not kind of missing a major detail here. So.
Massachusetts did have a program like this as a part of its reform that was rendered essentially illegal by the ACA. So there's some design stuff out there. And I think it also has an interaction with the IRS too. So that's part of the problem.
I was going to mention, I get asked this more often from my small businesses than anything else. So.
Oh, yes. We do too.
Yeah.
Yeah, that's good to know there's
Yeah.
interest. And,
Yeah.
so this is good. We've heard interest. We've heard some serious cautions or concerns. We know that federal activity is required, but
Or if there's suggestions of site boards that would help maybe mitigate some of those unintended consequences, that'd be helpful.
good. Okay, so
All right, so I'm moving right along here. I'm going to try to get through the next few pretty quick. So the last one kind of in a...
nobody here is worried about agent commissions. I'm sure there won't be a discussion on that.
Well, I was like, I don't think it's easy to explain, so maybe it'll be brief. But that's the next one I was going to go to, which was just in terms of market dynamics. We're actually looking right now around issues around changing agent commissions throughout the year, and that's something that other states have been looking at, and we are also now looking at. This concept takes that a step further, and doesn't just say you can't change your commission structure at different points of the year or somehow do a different commission for special enrollment versus open enrollment, but says that we would actually require standard commissions across the market so that there wasn't an ability to use a commission as a tool for steering from one carrier to another. So that would be the concept here.
I like that.
I like it.
I like it. Yeah, I do.
And when you say standard commissions, I assume you mean that the carrier sets their own schedule. It just is the same across the whole market.
It would be set by us, would actually be the proposal. This would be market-wide uniform commissions. So it wouldn't be set by the carrier. Every carrier,
exactly
carrier
the
A
same.
would pay the same commission as carrier B, so it wouldn't be more attractive to place business with one versus another.
So Shannon and
more
Shauna,
robust proposal than I thought.
could you just quickly elaborate? You both had a very quick response. And just for the rest of us who aren't tuned into agent commissions and how they work in the marketplace, just to explain why you react to that.
Well, first of all, in my office, pardon me, we don't base the work that we do on the commission that we're going to get. Now, that doesn't mean that we're not sensitive to the losses that we've had this year versus last year. So while our commissions have been decreasing this year versus last year, we've been building up other areas of our business, like in Medicare or in small groups or large groups. So the commission, having a commission structure that's more stable, consistent, that we can rely upon, is helpful. And again, no agent should be steering or putting people into a product simply because of commission.
Yeah, and it just incentivizing different, even sometimes consumer bases. When it was a % commission, you were incentivized to help somebody who was 60, but not somebody who was 20. And it seems so weird to me, like, so I'm getting more for helping that person than that person. I'm just helping a person, So I feel like keeping it, again, consistent and stable makes more sense to me. So.
Thank you, that was helpful.
And by the way, people ask how we get paid.
More so than health insurance than any other product, though. How do you feel as the carriers? I mean, is that...
Personally, I think it's workable. I think it has some merit. It'd be interesting to see what the impact is if we get to that point to a stabilized market where people are interested now in enhancing their market share and think about bonus programs and all that kinds of things, what the impact would be.
So I'll respond.
Well, they shouldn't work based on the earlier comment.
Well, but the reality is, at least, and this is not my area, so I'm totally beyond my skis, but carriers think they work. And to the extent that we want to have maximum tools for carriers to be able to say, this is what I'm trying to achieve in this service area or in this network or this product, you are removing a tool that at least carriers think is part of the toolkit that they use to balance their risk and to drive the portfolio that they want. I'll just throw that out there. So there is a reason that that it exists like this, and whether they're effective or not. And there may be other brokers that are more attentive. We all can understand that. So I would just throw that out there that you are removing at least some version of a tool from the toolkit.
Although it's one that if I had to go explain to legislators the effectiveness of that tool to the public, I would have a hell of a difficult time.
So let's keep going. We have a couple more.
Yeah, we have two more, and hopefully should be quick. So now kind of moving a little bit more into how can we have, I'd say, more uniform and I'd say stable costs in the market. And so these are I'm going to be back up at the top of what's labeled as page 3, so the second page of the matrix. And so The first of these would be requiring reference pricing to be used for specific procedures in commercial health coverage. And some of you may be familiar with reference pricing, some may not be, but it's this concept of looking at procedures that tend to be pre-planned, and I'd say, I hate to say this word, but I think it encapsulates this, a little more commoditized. There's not a lot of variance in terms of what the procedure entails. And there may be, there's probably comparable quality, but actually different costs being charged to do these procedures. So very commonly you'll hear talk about hip and knee replacements as an example of this. So things that you usually know you have to do in advance and you schedule in advance and may have the ability to actually look at two different hospitals and surgeons that would do this. The idea is that, let's say you've got Hospital A and Hospital B that would both be in your network to go get your hip replaced. And let's say, I'm just going to throw out numbers that they may not even be in the realm of possibility, but let's say Hospital A says that they will do your hip replacement for $25,000, and Hospital B says that they'll do it for $30,000, but that the procedures, the same procedure, they're both in network, and the quality is comparable. And what an insurance company would do in a reference pricing situation is that they would say, my reference price is $25,000. And so consumer, when you go to get your hip replacement, you'll pay, if you've got a deductible and a cost share, you'll pay that under both situations. It'd be essentially the same. And then we'll cover, for if you go to Hospital A where they're going to charge $25,000, we'll cover the rest beyond your cost sharing. If you go to Hospital B, you're going to pay not only your cost sharing that you would have expected, but we're also going to require you, consumer, to pay the $5,000 difference between the $25,000 and the $30,000 because you had an option to go get the same service, same quality at a lower price. And so the idea here is about driving decisions that are maintaining and improving quality, but also driving costs down. I think there are absolutely the devil's in the details in terms of how you execute this and how can you help consumers actually make informed choices so that they don't end up in a place where they had no idea that this was going to be happening and they end up with a bill they didn't expect, and they certainly would have gone to Hospital A if they had known, really understood what was going on. So I think there are some logistical challenges. This has been done in a few areas. California has done this with their retiree medical, and so that's something that's actually been pretty well studied and publicized, and so that's something I think for us to look at, kind of the successes and challenges maybe with that. Some commercial carriers have also done it, and so I think it would require some more review as to how to put this into play in a way that's actually actionable and doesn't expose consumers to, I'd say, more harm than not. And then really, which procedures would this include? Who would set the prices? Those are, I think, a lot of questions to think. So any questions about that one?
Very much like auto collision. Putting on that left front fender on your Acura, it takes this much time. And if you can present that something has to be straightened in order to bolt the fender on, there's some provision for that, but that's what it costs. And if you, as the provider of the owner of the collision repair shop, the body shop, feel like you want to go to your customer and say, well, I'm really special, so I'm going to ask you for this extra amount, go for it, knock yourself out. But this is what the insurance company is going to pay for that procedure. And body shops complain about it all the time. And body shop owners are also the ones with their own private airplanes. So,
Did you fly?
No, we're not a body shop.
Oh,
Here's the joke. When you have a meeting, the repair shop owners show up in a new pickup truck, the transmission shop owners show up in a new Jaguar, and body shop owners fly in their.
I have just a quick comment. This subject is near and dear to my heart, and one of the risks that I think can be associated with this is if the procedures are chosen, do those become loss leaders?
Yes.
And the what's not included becomes the expensive part for consumers, and that's then
That happens.
then it really.
And it's labor and delivery, I think, is frequently treated that way.
Right. Well, for instance, like right now, a colonoscopy might be preventative, but if you go in, there's a sign that says if polyps are found, it becomes diagnostic.
Mhm.
Well, at that point, a patient isn't saying, "Well, I'm out of here." Because, so does it shift from one thing to another, and the consumer's left holding the bag? So, I don't quite understand why there's not disclosure of all prices. So,
Similar question to my question last time. Are you proposing to have a reference pricing scheme that all carriers
Yes.
would implement uniformly
Yes.
across the whole market?
Yes. And not just individual. This was actually across commercial.
I think that would actually work a lot better.
That was the
because,
idea, not isolating a market and not kind of, I'd say, setting up, I'd say kind of creating ways to cost shift, like pretty explicit ways to cost shift from market to market. But there still could be some.
Just to quickly summarize this one, it's working in other insurance markets. It feels very new and strange to the health insurance market, but it is working in other insurance markets. And I think we've just surfaced a couple of significant issues to talk about. So with that, maybe cover the last one.
All right, so this one's near and dear to my technical insurance geeky heart. But so this idea is actually less focused on some of the, I'd say, the more kind of how do we change dynamics in kind of underlying costs, but actually looking at how do we, and as we've experienced in the last 3 years, we've seen rather dramatic swings in who in our individual market has the lowest rates, and how, what is the spread of rates from one carrier to the next. And I think, I just, full disclosure, I mean, a lot of people do know this, I'm an actuary, not a health actuary, but there are legitimate reasons why prices vary, and perhaps significantly from each other. Different carriers have different models, they have different cost bases, and we have been living in a period of uncertainty. And so what that means is that there is often there's not a right answer. There's a range of reasonable answers, and so that's really led us to a place especially with the uncertainty that we've been facing, where you haven't seen convergence across the market around a kind of, I'd say, node of rates. So, I think that as we kind of deal with some of these other stability metrics, we might see that converge and actually get to a place where there's less variation. But we're trying to look at, are there some other markets where we've seen this issue, and kind of how have we dealt with this? Workers' compensation is an example of where we've dealt with this a bit. And so the idea here is that you would actually look at gathering claims cost data across the market, and either this could be either us as the state or a third party that would collect that data, analyze it, and file with us. That's what happens in workers' comp, just so you know. To basically establish a benchmark projected claims cost. And this would just be the amount that would be needed to cover claims on average. It wouldn't include administrative costs or profit provisions or any of that. And that either we would be the ones who would be issuing that, or it would come to us for review and approval. It would be public and transparent, just as rate review is today. And what that would mean is it would set basically the starting point for the commercial market to begin its own rate filings. And so carriers would use that benchmark. They would have the detail of how we arrived at that benchmark and all of the assumptions. And there might be legitimate reasons, again, why carriers should have higher or lower claims cost provisions than that benchmark. They would have the opportunity through their rate filings to come to us and say, my rate should be higher by X%, and here's why, and justify that. Or it should be lower, and here's why. Or it should be higher in this part of the state and lower in that part of the state. And so there would really be still, I'd say, the same type of process that we go through today, but that everybody would be starting with the same information. And then the other piece of that is that carriers would file their own administrative cost loads and profit provisions for our review that wouldn't be set by the benchmark.
So Laura, especially in the first year of the market, I saw a scattergram, and you saw the high cost carriers and the low cost carriers, and you wondered if they were pricing in the same market, because there was such, now that's over 3 years that started to divert to
a little bit. Yeah.
The ones I've seen, the scattergram starts to get a little tighter, but you're still seeing pricing that's spread more than you would expect it for people pricing to the same market. So this proposal would probably eliminate that because you'd say everybody's starting here, and then you tell us where you think you.
We're starting with the
It would
same
tighten
set
it.
of facts,
Tighten
right?
it.
Because I think that's the piece too. Is this isn't a way for us to be setting rates. It's a way for us to make sure that really there is, I'd say, a common set of baseline facts for everyone to work from. And I think that there will probably continue to be legitimate reasons why you're going to see variation from carrier to carrier and different plan offerings and that sort of thing. But the other element that I didn't mention that I think has been challenging is that you've got a little bit of this dynamic of each carrier not really knowing how every other carrier might be viewing the market, and I think that that's also led to some of the switches we've seen in terms of low prices. I think it's disruptive, frankly, to consumers to have to kind of figure out year over year, kind of, especially if they're looking at tax credits being tied to a second lowest silver, that makes it more challenging, I think, for folks to plan. And so this would be an idea, a way for us to get some more stability. And we've also been really careful. Some of you may have been involved or followed that there was a discussion of establishing a range of rates.
Pretty sure I was the only one who was paying any attention.
Maybe. Well, we were too, but that was kind of more the idea that we'd set a range of rates, and as long as the rates were within that range, everything was good. This is not that. This is much more around starting with a baseline so that we're all really at the same starting point, and there still will be variation from carrier to carrier and different parts of the state that will be legitimate, but that we will, I think, have a little bit more stability in terms of how we're viewing that. So this is I think has some things to discuss. It's rather complex. It might lengthen timelines a little bit too, depending on how we approach it. So I think that's something we have to think about.
So let me ask, any last questions on this last idea? I'll pause there, and then I want to ask Pat, just give us a sense. Today was FYI only. Next steps, you mentioned during your introduction that this was going to play out between now and the start of the legislative session. But are there any questions for Laura on that last idea, or Pat, tell us what the
so this plays a little bit outside the ordinary agency legislative concept process. We don't need to turn this into a bill that gets introduced in December, which is typical for us. We have a placeholder bill that we took some language from another bill and substituted it in just to get the right kind of a bill. And when we get to the place that we think we've got a package that hangs together and that is broadly supported, we'll have that other bill move forward and substitute the contents here into that bill. It's called it Gut and Stuff, charmingly enough. And so the idea would be that we would continue to socialize this over the next short weeks, refine this package based on input here and from others into a number of these things we think will hang together, and turn it into what we think is going to be the package that we're going to work with and we'd like to come back to then probably the next meeting of the advisory committee to ask for a thumbs up, thumbs down recommendation on whether you would support our pursuing that package. We think it's an important role for this committee to advise the legislature on exactly this kind of a concept of things that are designed to affect the structure of the individual market.
I have just a question on the last, just from the carrier's point of view. I'm not sure I understand how that would make the market more stable, and how do carriers view a presentation of here's the fact, justify your pricing from there. Yeah, how does that?
Is that a question for me or for the carriers?
The carriers.
Well, the carriers think about the answer. While the carriers think about the answer to that, let me jump in and offer our perspective on why we put it in here. And it's this notion of widespread of rates. We think now after 3 years, one of the things that has been inherently destabilizing about the market is blind filing of rates that result in a wide spread in rates from top to bottom that cause shifts of tens of thousands of customers from one carrier to another. We think that's disruptive for the individuals who are insured. We think it's potentially disruptive for the carriers themselves. It renders it almost impossible to do population health kinds of things that require having a customer for a period of time to be able to have an investment make sense. And then compound that with when we were working with carriers to try to get them back into rural parts of the state, we found consistent with that one of the biggest fears they had was being an outlier on the low side, not wanting to go into a market even if there were other carriers in that market and find themselves with the lowest rate and all of a sudden basically picking up all the risk. A tighter banding of prices was more attractive for this. We think this provides a fact-based way to get to a tighter banding of prices and try to get some of that instability out of the market.
I mean, I would say, there's many reasons for the instability of the market. One of the reasons is somewhat self-inflicted, especially in the first couple of years. We have had data available to us, not quite this rigorous, but there has been, the States commissioned a study that's provided an idea of where market average rates should be, kind of based on what we know about the market. And folks flex their assumptions pretty dramatically from that, presumably to gain market share. And that does create instability in the market when you've got this huge range. So I think the potential for this is it creates a much more uniform starting point that then you've got to really explain. I mean, you have to explain anyhow, but you really have to explain how you're varying your assumptions from that point. That's, I think, the underlying logic.
Is that responsive? Okay. I don't want to cut off that. We can probably talk about this a while longer. That's helpful. Jesse, last comment on this.
Really quick process question on the matrix. It makes sense to have the presentation about this at the next Marketplace Advisory Committee be thumbs up, thumbs down. But if committee members or anybody else wants to make a recommendation saying, I like ABC but not XYZ, or I would like A if it was modified in this way or something like that, what's the best way to get that feedback?
So, are you asking kind of to us as the department? Yeah, well, I think so. I think at the end of that document, I want to say that I think there's contact information.
So just email you?
So just email it.
Yeah, just email it. So, and you can send it. And probably the best, I'd say the most direct way to do it is send it to me, because I think my team's been working the most on some of the details, but any of the three of us can
socialize it. I mean,
feel
free to share. Alliance. I mean, there's a lot of groups represented even just in this room, so socialize it. Get
public, obviously, but
public document at this point. So excellent. Okay. So thank you, Laura. This is a lot of stuff, represents a lot of work. We really appreciate the department's work on this, and this is great.
Very creative.
Yeah.
I like that.
Yeah, I was like, I probably didn't mention at the beginning that we had a much longer list when we started. We had, and I mean, I can't even remember the craziest ideas on there, but we basically did some blue sky thinking where we just said.
We have reporters on the line, so you don't want to say the craziest.
Anyway, we tried to kind of suspend all disbelief and try for what we thought was really useful.
So I do have one more comment, just because of last night, I guess, and a comment that was made this morning is that one of the things that certainly affected maybe the election is people opening up their bills and finding large increases on their health insurance or leaving the market. And so for all of, I just want to make sure I understood. What we're talking about could be one or more of these proposals put together, because if we don't address cost and quality in the individual market, shame on us.
Agreed. And I think we looked at this as, I'd say in the ideal world, we think this works together as a package, but some of them are, I'd say, less critical to work together as a package than others. But I'd say the one piece that is important to remember, and not to, I always hate to say this, but when we think about our levers as the marketplace and DFR, so basically the regulatory role combined with the marketplace role, our levers are actually over the financing of healthcare and looking at the insurance piece of it. And so we have, I'd say, less direct control over the underlying cost of care. And if you think about what's driving rates, what we're seeing is that, the vast majority, actually in the first couple of years, more than 100% of every premium dollar was actually being spent on medical care. And so I think it is really critical to note that we have to address the underlying cost of care. It's not as simple as fixing the financing system around it. It is a piece of it, but it is bigger than that.
Okay, let me close this there. Thank you, Laura. That's a nice note to close on. And we haven't lost sight of that, so thanks for bringing that up. Well, Deanne is sort of limbering up and getting ready. Let me we had a couple people come in since we started, so let me just quickly review. the plan here. So we're now going to have hopefully about a 45-minute presentation on the basic health plan from staff. We can ask some clarifying questions on that, but then we're going to go to a public comment period. And again, I see some people here that I know have strong opinions, and we're going to have a dedicated time for public comment. And when we get there, of course, I'll ask people to be brief and to the point because we do have a limited amount of time. We'll then close the public comment period, and the advisory council will go into a discussion leading up to a motion and a vote, and we'll conclude with that. And maybe at the very end we'll approve the minutes, which I think I was supposed to do at the beginning. Deanne, please.
A question. Has everybody got a copy of this? Is this for their extra copies of these?
There were extra copies over here.
And there's one extra copy over here, and also just be able to look at the screen because there's an extra copy.
I think folks have.
Okay. All right. Good. Well, first of all, I have to say, I just love Oregon. You know, all the years here, and looking at the table at Ken and all the many years that some people have been at work on some of these things together, and the references to yesterday, and a lot of people, I think, were expecting a different kind of discussion about some of these things today than perhaps we are thinking about now. But that we had this history of getting in, and Laura did such a very nice job of going through the kind of broad concerns that we want to think about. So the idea today was much of what is in these slides are what you already got in the weekly report and in the DCBS kind of very draft staff response to kind of get out to all of you. And then there are a few slides that are new. So the intent is not to spend a lot of time walking through each slide, but to leave time for the advisory committee to be able to discuss and ask questions and get clarification, make comments, that kind of thing. But on a few of the slides, we will spend a little time. So if we could go to the first slide. Oh, Victor, don't expect me to forward slides and talk. It's not in my skill set. What I wanted to do here, because one of the things we tend to do with the VHP is to just jump in and start talking about it, or how to do it, or how to make these things happen, but to really talk about how the ACA sort of envisioned these programs. And so the vision was that we'd have expanded Medicaid, and here it's very simplified, really the children in the CHIP program up to 300%, and adults in general up to 138% of the federal poverty level, and then the category for pregnant women up to 190% there of the federal poverty level. That we'd have this kind of Medicaid expansion, but then there would be through the exchanges, as they were called then, and marketplaces now, there would be using tax credits, or for people below 250% of the federal poverty level, cost share reduction plans. And these are very rich plans for people below 200%. And again, I think not spending a lot of time on that because that was described pretty thoroughly in your report, that these two things would come and meet each other. And so that up to 400% of the federal poverty level, there would be a way of helping to just gradually provide less and less subsidy and get more people insured and more people with access to coverage. And the other thing was, because people with certain immigration status issues, such as being here less than 5 years, or the COFA population, and some other immigration statuses were banned from Medicaid coverage, that was also an option with the QHP, that people could enroll there. And then later, when they realized there was a subgroup of people who didn't qualify for free Part A Medicare, they also got rolled in. So through the marketplace, right now, this year, we had about 6,000 people below 138% of the federal poverty level who enrolled in marketplace QHPs. and almost half of them are below 100% of the federal poverty level. And so these are people who couldn't enroll in Medicaid but are enrolled in a QHP now. But the idea at the time was that these two would just meet each other. Then within the ACA, there was an option to take a subset of the enrollees at 200%, and this would also include the lawfully present immigrants who were otherwise banned. It would not include people over the age of 65, but that states then could have the option to set up a separate and program that could be different than a QHP. It gave the states that flexibility. If they were willing to accept more money, they could have that flexibility. And also, if they didn't charge any enrollee more than what they would pay in the way of premium or cost sharing for a QHP. But that's how we kind of have this option out here that we're looking at. So we'll move along here. This little history is just to give you a snapshot of how we got here. And some of you in the room know this history really well. But for those of you on the advisory committee, maybe the first view of this is when, in this final step in House Bill 4017, it's directed to DCBS and stakeholders and this advisory group, this advisory committee, to consider and report on the VHP recommendations and whether to do a 1331 waiver and to come back with some responses at that, and also to consider and report on State Innovation 1332 waivers that could be about a number of things, including possible alternatives, or just to come back with possible alternative approaches for achieving the VHP objectives. The objectives that we're going to look at in just a second here, that was defined by this stakeholder group that came out of House Bill 2934. Those first two bullets there, the Oregon Health Authority, which many of you in the room know this very well, but others, just for your information, had a process that led to a set of recommendations that then got incorporated into House Bill 4017 that we were directed to consider and address. Not necessarily to do, but to consider and address in all of these analyses. So if you go to the next slide. These are the recommendations that when you looked at the Wakely Urban report, and there will not be a test on the report, that was a rumor. But when you look at that report, this is what is described as scenario 1. These are the recommendations that came out of the stakeholder group that were then incorporated into 4017. And the scenario 2 took another recommendation, which was, it's not a recommendation to include dental, but we'd really kind of like to have dental, so we'd like to know what would that cost. And so scenario 1 and 2 really represent the stakeholder recommendations. The other scenarios that were modeled were to give people ideas of what it might look like, what it might cost if you were going to do variation. So not do 12-month continuous enrollment, do things with dental, these kinds of things. That's why you have all those many options. But today, as we go through the slides, we're going to be looking at just recommendations that include these points. And the next slide will
and that doesn't mean that the legislature couldn't adjust these at some
Correct.
point. What it means is in order to have an analysis, we had to make some certain assumptions and parameters. So we're not necessarily going to debate those today. Those just allow Wakely and the state
Right.
to proceed with an
Right.
analysis.
These were the assumptions that went into costing this. Oh, and the other thing I should probably say is, just as in 2014, all of their work was built around the economic incentive. It was basically the more you subsidize, the more enrollees you get, and the mix of the demographics changes. The bigger the subsidy, the more young and low health risk, healthy population people that you get. So they did not consider these other recommendations either in 2014 with the study that then was updated. But I just wanted you to be aware that these were also recommendations they made, and if the state were to go forward with a BHP or a BHP-like program, these are the kinds of considerations those stakeholders group would be asking to be considered. The major question we really tried to get at in responding to this analysis was a question that was posed by Representative Greenlick and by others of what problems are we trying to solve. And so we tried to answer the question when comparing a VHP to a QHP. Would a VHP increase affordability and access? Would it increase equity and decrease disparities? Would it lower the uninsured rate? Would it affect the individual health plan rates and market stability in one direction or another? Would it decrease enrollee churning and increase simplicity? And again, while we use the term VHP, it really was looking at with these kinds of subsidies, with this kind of approach, what were the findings? And so on each of these slides, we kind of summarized a few of the major conclusions, not everything that was in the report. But what I'd like to do is just not really talk. I'd like to really not talk, and just pause and on each of these slides and allow you to ask questions or make comments. This one I might explain a little bit because this one is a little bit counterintuitive. This has to do with the fact that some of the people in this year, it appears about 6,000 of these, the people who were below yeah, thank you. Thank you. That they deliberately chose a bronze plan. And or could have deliberately chosen a bronze plan, get this said correctly. Some people are still probably doing it accidentally, and we're making all kinds of efforts so that they won't do that, because it's really not a good choice for a number of people, but for others it could be a good choice. And so this is just one of those. We pretty much made the statement for virtually everybody, increased subsidy is going to increase affordability and it's going to increase access. That's just sort of a no-brainer. But there is a group of young and healthy people, if they are making the decision to choose that bronze plan, and making that fully informed, they would in fact see their premiums likely increase. And Sean, I know you. Do you want to say something about that?
Well, yeah, there's a lot of reasons why people choose the bronze, and it's usually around they are healthy individuals who have decided that even though they might get some cost share, usually they're not at the 94% of the cost share, they're at the 70%.
Yeah, the people above 200%.
Right. So they're not seeing that big of a savings, or that they're not seeing that much cost share. So they decide on going with the bronze because it's less expensive.
Yeah, we're still very concerned for the people under 200% that they're making a correct decision when they make that choice. So we don't know how many people this might affect, but to be aware of it.
So, to be clear, I mean, the way I would normally use the term total healthcare coverage costs would be all costs associated with having that coverage, as opposed to just premium, because they would see a premium increase from 0 in a lot of cases to something, although that something would be pretty small, but the total cost, if you include all out-of-pocket costs, would dramatically go down.
It would depend. If the people who truly are low risk and see the doctor maybe once or not at all, I mean, that's the part we had to concede in this analysis, and that they, but not to dwell a long time at this point, but to understand there are people, and they've come forward with us. So yeah, it's the person who can now get a bronze plan for $10 or
10
zero,
cents,
a month, and has no health issues, and under a proposal where they would be responsible for 50% of their of a QHP premium. But we have no data to know how many people this is. So this is just an acknowledgement to say that yes, it would affect some people.
So, Dan, can I ask just a question? I'm surprised about the no data, because I think of you as having a lot of data. So do we not know who is subscribing to bronze plans, and what percentage of those people are getting a subsidy?
We know those kinds of things, but we don't know what their health care expenses are.
So you don't know claims associated with those?
Correct.
And I know this is a question I've asked a lot, but isn't that information available?
Not at that level. No.
So we don't know claims made at the bronze level?
We
What's in
don't-
the rate filing?
So we don't have, so maybe I can speak to this. So DFR is the one who actually receives the rate filings. We do not currently get a breakdown of claims costs by plan level. That is information that carriers do have, but that is not something that we're getting kind of at a level to also be able, and also to be able to look at. It's more than just at the bronze level, but like getting down to the individual level to kind of figure out who these people are and where they would kind of move into a BHP plan is much harder. We get higher level aggregate data.
It's that population data, and that's Jesse's point. At the population level, that's where the rate building happens. But it's sort of the conversation you and I were having the other day, Cindy. About talking about the young adults, and so we have no idea, how many of these people are. We just know the ones who choose those bronze plans, and we have been pushing that number down. So
Cindy, sorry again, say more about that, because that was a question that I had as well, which is we're going to get later on, we're going to get to the impact on the current marketplace risk pool, and so to the extent that we can pinpoint, the behavior of the unhealthies under this scenario. So could you say more about that?
Well, and quite frankly, I maybe shouldn't admit to this, but I'm an old healthy, and I have a bronze plan with an HSA because I'm healthy and I don't go to the doctor. It's a very large,
it's a rational choice.
It's a rational choice, and a lot of people here talk about it as being irrational, and it's completely rational for me and my 27-year-old son and my 30-year-old son.
Yeah.
So I find it very, very interesting that our most problematic demographic seems to be the 19 to 34-year-olds who believe that they don't need health insurance, and we keep saying that they do need it for whatever reason. And I think if we got down to, if they're choosing the bronze plan, how many are choosing the bronze plan? What are the claims made? I believe that's important information that we don't have, because it may be mispriced. It may be mispriced, and the risk might be. I mean, we might be able to do something for them outside of subsidies and completely rejiggering.
So I shouldn't wade too much into this because I have not directly been involved in the BHP work. But I think that the challenge is, and we do when we review rates I'd say the different rates for different plans are looking at whether there are justifiable data to support how we're pricing this bronze plan versus that silver plan. That is part of what we look at, but it is in a higher level aggregate context. And the other piece, though, is that it's not just about the claims cost that drives it. There's also there are requirements in terms of the design of bronze, silver, and gold in terms of the percentage of claims costs they cover. we have to rely on an actuarial value calculator that actually helps also to determine differences in the value that's going to each of these plans. And I hesitate to get too technical, but there's also our requirements that we not allow selection to influence pricing for different plans. Basically to say, if sicker people buy richer benefit plans, sicker people buying gold plans, then the gold plan should cost more. That's actually not permitted. So you've got an issue with using just claims costs to determine differences in prices between plans. It's just not, unfortunately, that simple. I think it's absolutely logical to think about it that way, but from a public policy standpoint, and even before the ACA, there has been, in Oregon, a concern about allowing selection, basically this idea of sicker people buying certain plan types to influence the differences between the plan types. So that kind of, it's a population level health issue is actually being spread across the pool, and the differences in the plan types are actually more keyed off on the differences in the benefits that are being provided by those plans. So that's a really key piece. And then the other portion of this is that if you're looking at a portion of people who are buying bronze plans who would be eligible for and interested in having a basic health plan, that is at a level of detail that we do not have, and so that further complicates it.
And I think, Cindy, the people who had asked that we make this point in the report are really making the same point you're making, because our initial conclusion was, of course, more subsidy makes it more affordable and, increases access, and the pushback was some people, for good reason, are deliberately choosing a bronze plan, and if their estimation about their own health risk proves to be true, if they actually had to buy that plan at a higher premium, that group, and we don't know how many people that is. So that's why that point is in there, not maybe to dwell on it too long. It's just to acknowledge that it wouldn't be true for absolutely everyone, but overall we find that for most people who are currently enrolling in the regular QHPs, that it would improve their affordability.
The ACA also imposes requirements on the relationship between the highest and the lowest rates, so related to age, and it reduced that pretty dramatically from where it had been previously. So that, there's a sort of from a policy standpoint, there's an intentional subsidy of younger folks or older folks, and it's kind of built into the structure.
Sean, I have a question, and we'll ask Ian and move on to the next.
I just wanted to raise that the plan choice is still a valuable thing for the people who are choosing the silver plans because they do have regular costs. They've often got continuity care issues, or the different system plans can benefit them more, so there's going to be at least some resistance to being put onto one plan with set benefits, and the whole, if you like your doctor, you keep your doctor issue.
Don't go there.
And
that's what we were trying to make. All right,
Sean, I have a sharper point on it.
Just a quick question: Is it? Do we know if Massachusetts, which has been doing this for so much longer, has access to the kind of data that we're looking for?
Massachusetts doesn't really do a basic health plan. They have a whole different design.
All right.
Yeah. So
that's the answer.
Okay. Equity and disparities.
All right. Well, first of all, the first point, I think you can. Well, I will be quiet and let you just read through these and ask if you have any comments or questions.
On the next slide, if I could just ask you just to summarize, and I know it's in your report, but in public here, what comprises that number? In other words,
how do you get to that point?
Yeah.
Okay. The next slide is on the uninsured rate. And here, for those of you who are sharp-eyed, which at this point might be kind of hard this afternoon with everything you've been looking at, but you may have noticed when you read before, they approximately an additional 27,000 people would be enrolled in the proposed BHP. So why would that only reduce the uninsured rate by, or not raise the number of people actually, by a little over 12,000? And so first of all, to explain that, the model that Urban uses, they assume that there are people who currently meet the federal standard for being in an unaffordable workplace or employer-sponsored insurance, but they haven't made the move to come to a QHP. So their model assumes that with additional subsidy and incentive, that those folks would disenroll from their unaffordable employment-based coverage and enroll in this more highly subsidized program. This is nothing for people stuck in the family glitch, where the definition is that they're, whatever we may think that it is affordable coverage, but that's why those two numbers don't line up. How it gets to this number of 24,600 people who are BHP eligible uninsured, again, this is the Urban Institute's kind of projections into 2017. They start out with about 101,000 people who are uninsured, below 200% of the federal poverty level, but not all of those people would be eligible for a QHP or BHP. Many of them are stuck in the family glitch or have other things that would make them ineligible to enroll, but they are living in Oregon and they are projected to be uninsured. So out of that 101,000, you would have about 24,600 in their projections. But these are all estimates generated by their data using the American Community Survey information and other data sources. So, but that's how.
As it says on TV, actual results may vary.
Actual results may vary, and in your mirror it could be closer and larger.
That's right. Yes. This does help set at least an estimated.
Yeah. So the proposed BHP would, take a pretty substantial bite out of the folks who would actually be eligible, and so that would be the effect on the uninsured there.
A question about the previous slide, if we could go back to that for a second.
Oh, Jesse.
Maybe we can, hopefully we can make this brief, but I'm confused about the final bullet, because maybe I'm just misunderstanding what that's saying and what the language in the report around that meant, but it seems to me that it's not really increasing disparities, it's just not solving those other problems.
It's widening the gap. When you look at Oregonians between, below 200% of the FPL, there's people in different kind of categorical eligibility sorts of, they're in employer-sponsored insurance. And part of why it feels so real at the marketplace is when people become permanently disabled or they turn age 65 and they have to leave QHP enrollment and go into Medicare, it is a gigantic cliff they fall off of. I'm hearing some, you might want to, that, you see that too. Okay. And
I'm not denying that that's a serious issue and that the family glitch isn't a serious issue. It just seems like saying that it's helping one group of people while not helping another group of people with an entirely separate set of problems is not really about increasing disparities.
I would say it's an increased disparity because we're offering more benefits to that subset. So that subset's benefits are potentially increasing because the costs are going down with the BHP program, thereby increasing that already perceived disparity that exists right now.
This is basically
this is one of those awkward things of trying to describe how you're dealing with the population on something. And so we're going to try to do some simplified version of Table 1 here that was in your report. But just to make it clear, for the people who are eligible for a BHP, or this increased subsidy, if you could, essentially that first bullet is the COFA program, the wraparound that right now is happening for QHP enrollees in January 2017, but would be for everyone. That level of subsidy, there's no question that really is increasing equity within Medicaid eligibility.
Okay, I think we're at agreed agree to disagree on that one. I think both points are well made. And,
Yeah.
I don't know that we'll resolve it. I appreciate the dialogue. I'm just asking you to jump in now to the third point here.
Yeah, well, we'll just stop
The third
there.
category.
And this is a really, Laura's presentation has really spent a lot of time on the individual market stability. I guess if there's any questions or comments about this slide.
One observation I had was 1.5% may not seem like a lot now, but in an ideal world where we are another year, Laura's just looking at me like, are you crazy? But where the premiums are starting to stabilize and premium rate increases start to shrink, that still is a significant amount. Right now, on the heels of 30% rate increases, it doesn't feel significant.
Yeah, but if we're talking just to medical inflation at 4 or 5%, yeah, that's
I guess that's better.
25% higher than that.
Yeah.
And we're trying to think about ways to kind of notch that down, and even anything that kind of pushes in that direction just makes it that much more challenging.
Dan, you might remember, was it 80,000 that were going to be pulled out of the individual market under the BHP? Does that sound?
Yeah, it's close to 90,000 who are eligible, but
Okay.
this year we
Potentially
only
be.
have 52,000 who
Okay,
are
okay, so that-
enrolled, who are under
Okay, so how many were
200%.
eligible?
Right.
90,
It's
potentially
yes,
90,000?
almost 90,000.
Okay, I thought that was
numbers.
significant when I saw it, and I guess
Yeah.
surprised it's not bullet pointed out there.
So given that number,
Yeah.
the 1.5 doesn't seem to pass the smell test. I don't know. That feels.
Yeah.
First of all, it's a big number, but second of all, I don't know. I don't have any basis to say that. It just feels like a really low impact for pulling these folks out and putting them in a separate risk pool and how that would impact it.
Several people on the subcommittee asked that we make note of the kind of sub-bullet point there that Wakely was grilled a little bit about this, and their response was just in the model they made the assumption that carriers basically having the same information, they would at least would estimate the same impact, but they acknowledged in the real world that carriers would make their own judgment about what impact it would have. So
it could be more or less.
And this was when a 20% decrease in the individual market share, right? Once you took out people from basic health plan.
the current number who are enrolled is only 52,000 out of what's projected in 2017 to be almost 90,000. And even in the proposed BHP, the increased enrollment would go up to, I believe it was 77,000 for scenario 1.
79.
79, thank you. And so there's no model that assumes everybody's going to enroll. But when you start pulling that number out of the individual health plan risk pool, because not anyone can choose it, and Laura, please back me up on this description, correct me on this description, is in order for people to be considered part of the same risk pool, everyone needs to be able to buy a plan in that, and automatically this is only people below 200% who fit into this kind of eligibility, whereas in the individual health plan market, everyone.
Yeah, so we're just cutting down that individual market by about 20%, was my understanding of the size involved.
Yeah, the total.
The existing individual market.
Yeah, which again, not everyone is enrolled.
Mm-hmm.
So,
which is fairly small as it is, it's like 3% of total enrollments in health insurance.
So keep going with that thought, Sean. I want to make sure we're
I was
getting your
just
point.
trying to get an idea of the size of that, because we're already concerned about carriers dropping from the marketplace as it is, and that can, I mean, Providence's rates increased 5% after the Oregon Health Co-op dropped, so if the main risk I see with that 1.5% numbers that could be much higher if we lose a carrier because of this. One carrier would be eligible to quadruple that. For the
And Wakely conceded that. This is kind of what produces in their sort of in a vacuum sort of model.
Yeah. Yeah, thank you, Bill. Okay, yes, we want to make sure we have the full time for public comment.
How are we doing?
Attorney and simplicity. We're all about simplicity.
Yes, we're always.
State marketplace.
Comments and questions.
Any comments on this? I mean, I wrote the handout and then the report laid this out. Anything that struck people on this?
Yeah, what was simple? I get the turning, but what's the simplicity? Yes.
I have a question about this actually, in terms of how this would be administered if we actually did it, because enrollment would presumably, since we don't have a portal that could accommodate this, enrollment would presumably have to be done on paper. If someone who was in the eligibility category went to healthcare.gov and signed up for a QHP, would they then have to pay back the tax credits at the end of the year because they didn't go into the BHP program? How would that be handled?
First underlying hypothesis, part of what the blueprint to complete, which is a template that describes how you would do a BHP, is tell us all about your IT system and tell us how it coordinates with your Medicaid and with your QHP system. Tell us how people will have their care coordinated. Tell us how they will be seamlessly transferred back and forth in this existing IT system. So there is no assumption that you would be having, as we've been making lots of jokes that we were going to have Chicky running around doing the expanded code for this, but no, it assumes, and in fact, I think it's the next slide. Well, I'm going to let Dawn talk to the.
You know, Jimmy, I'm happy to jump into kind of that operationalizing piece really briefly, which doesn't mean that we don't appreciate the significant challenge of our operationalizing these and the technological limitations, but I'm just going to be brief because it's really there isn't that much to talk about because the challenge for the technology is so significant. So there really are two options. We currently use the federal marketplace, and they have been pretty clear that they are not going to customize the federal technology to accommodate a basic health program. I don't see that changing in the near future. The second option is some sort of Oregon customized technology, and it would have to be a customized technology. There is not a technology, an off-the-shelf technology system that would be available that we could take from another state. There's only 2 other states that implement the BHP, and they are pure state-based marketplaces, so they have their own eligibility and enrollment system. So it just would be a significant challenge, and it would the Oregon path would mean that this group would have to revisit that very comprehensive conversation that you guys already had earlier this year about implementing the technology. So really we're very restricted when it comes to technology in being able to actually implement this, especially with the number of enrollees that we think could potentially move over. It's not as easy as having Chicky in a back room doing this as a manual process. So that's it. And again, I'm not trying to go over this briefly to decrease how important the technology conversation is. I just know we have time sensitive and yeah,
Donna,
absolutely.
Where in the report are the technology costs estimated?
They're not in there. That is a very key point, exactly. So the Wakely report does not include the cost of building our own Oregon-specific technology.
It only includes operating it in the administration. So and this is essentially standing up a marketplace eligibility and enrollment technology. I think that's what would be necessary.
Okay.
Anything else on that, or should we get to the cost projections?
Let's do the cost projections, and then I think that'll be a nice handoff to Commissioner Cook.
Yeah, maybe just doing those two. Again, this is scenario 1, and is that top bullet, and then and if you added dental, it would be $99.2 million. but this is for the proposed VHP.
First line's pretty
The
simple.
deficit here is basically a state cost.
You get that. It's just, the state would be on the hook for this.
Yes.
And this came from that chart in the report. Those
Yes.
of you who saw it, that had all the scenarios and all the deficits.
Right.
And so this is for scenario
One,
one.
which is, again, the proposed stakeholder recommendations. And maybe, because we're really running out of time, one of the things that had, a request that we had was if, as the department considers VHP-like alternatives, the next two slides in your packet, and these are just very draft, but right off the bat, seeing some savings of not having with a wraparound subsidy type alternative, without having to have that separate system, having all the tax credit and cost share reduction coming to the state, not having to stand up all these separate eligibility, enrollment, administrative kinds of requirements and the savings that comes from that. We initially thought that this would require a 1332 waiver, and that's a longer discussion, but not only would it likely not require it, it's not something that they're even welcoming or interested in even prior to yesterday. So, but we wouldn't need a waiver for the state to do that is the likely expectation. And then the one stakeholder recommendation that couldn't be operationalized in a QHP with a wraparound subsidy is a 12-month continuous enrollment. We would be able to give consumers below 200%, more choice, and that is, it would be possible if it was designed that way that people could still choose a bronze plan and not choose the more highly subsidized silver version or something. That it would just depend on what you all decided to do if you did something like that. People age 65 plus could be part of that because they're part of the QHPs. Then you'd have whatever churning would go on between two programs rather than three. You would retain the enrollees in a single risk pool. You wouldn't be setting up a separate risk pool. There would be some greater possibility, particularly with what the Oregon Health Authority is looking at now with House Bill 2828 considerations. Several people, particularly I think coming from the Asian community, have brought up the idea of having something FIOP-like to address people in family glitch situations, whatever the future may hold, which is feeling very fluid these days. A state-run subsidy might be more flexible. So that's just thrown out there as a straw man kind of proposal. And
So yeah, your last slide really summarizes, I think, if you want to just run through those, because you talked about
the potential recommendations.
Yeah.
These are all things that have come up. There were some other things that we kind of threw out as staff, but these were things that really came up from the subcommittee and conversations we've had on the side with people. One is, go ahead and try to do that 1331 waiver VHP. Then there's that alternative that I just walked through of designing something within the state that has a wraparound subsidy, but within that QHP sort of structure. You might consider doing a targeted subsidy that just tries to increase the equity for everyone below 138% of the FPL, for example. That would be a much narrower and much less expensive, but that could be an option, particularly for the folks with the immigration status. Then there were like advocacy things, like advocate for federal changes to the family glitch rule and advocate for federal changes for people who are get their additional assistance for Medicare enrollment, so that when they leave from being either in Medicaid or in QHP, that it would be a seamless kind of thing. They wouldn't fall off this very dramatic cliff that they currently typically do. And then the reinstating the fee up like program came up several times. And then of course it's just try to keep doing what we're doing and do it better and try to address some of the concerns that come up. Those are all the things.
What is QMB? Refresh me.
Qualified Medicare Beneficiary. This is commonly called the QINB program, and it's administered through Medicaid, but it's a federal subsidy, federal set of subsidies. So when someone leaves Medicaid, the expanded Medicaid, they will only get 100% free kind of coverage if they're below 100% of the federal poverty level. It's not matching up, and then between 100% and 135%, they get some increasing assistance, but again, it's less than expanded Medicaid. Then when they get to above 135%, up to 150%, they get a little bit of help with pharmacy. Above that, they just really get nothing. They're on their own. And so when you compare that to the QHPs, and that's where, we at the marketplace, particularly with the Shiva program, get a lot of phone calls from people who are in shock when they have maybe been paying a few $100s a year and they are suddenly expected to pay a few $1,000s a year. That's it.
So Dan, thank you. This is a lot, and Ron as well. And I know you'll stay here for our deliberations. You'll be available for us as a resource during our discussion. But as we close out this section, I just want to ask, are there any questions about what we've heard right now? And we certainly have a chance to ask questions during our discussion period. But if not, I ask you to stay seated and don't go anywhere. And let me do this. Let me just ask people, regardless of what your comments are, can I just ask people to raise a hand if they'd like to participate in the public comment period? So we have a rough sense of how many people. So I see 1, 2, 3. You got a sign-up sheet?
Yes, Gwen and Jessica signing up, and nobody else has.
So 3 so far.
You're asking, yeah.
Okay. So everybody can do the math. John, come on up. Everybody can do the math of 3 or 4 people divided into half an hour. Okay. So ask you to keep that in mind, John.
Well, Mr. Chair,
and feel free to use less.
Mr. Chair, just to follow your instructions as best I can, that you asked us to be brief and to the point. I'll do my best. First of all, for those of you who don't know me, John Muller with the Oregon Law Center, and thanks for the opportunity to comment today. I want to start off with a little bit of a personal comment.
And John, you're welcome to sit or stand, whatever.
It's okay. Well, I'll explain a little bit why I'm standing. When Pat gave his wise counsel and breathing exercises to start out the meeting, I had a little bit of a different experience. I was up quite a bit last night and wound up, as I sometimes do, dreaming in Irish, and was quoting Yeats when I woke up about how the world is full of trouble and is anxious in its sleep. So I think that all of this discussion can't be engaged in without recognizing that elections have consequences. For a moment, I want to first also to express my gratitude to Pat and to all of the staff at DCBS for really the engaging work that we had and the work of the Marketplace Advisory Committee and the subcommittee. Really some very good discussion. But we're really at a very different crossroads right now. I also want to acknowledge Oliver from the Oregon Health Authority. We're in a situation where, when we look at that for just a moment, the 1115 waivers that Oregon has put forward are also going to be in question. There'll be new people at the Centers for Medicare and Medicaid Services. So I would not be true to how I believe if I didn't tell you all that I'm extremely worried. And Dan, I just want to say to you that I've been a Kaiser participant for almost 40 years now. And I bring that up only because I've had the privilege to be able to have health insurance through work. And I'm here today again to speak to the people that we're concerned about as advocates. When the ACA passed and a number of us started to look at some of the provisions in the ACA, we came across the basic health option as well as the 1332 waiver process. So we hitched our thinking to basic health. And we formed a group that has our values in our name. We're the Inclusion, Affordability, and Innovation Coalition. And later on, we morphed into the Mend the Gap. If you've seen the Mend the Gap report, you know the things that we're talking about that are lacking here in the state of Oregon. So as I stand here today, I'm thinking about those people that are between 138 and 200% of the federal poverty level and those excluded populations. And the challenges that we have, because again, elections have consequences, and not to politicize this, but we're going to be challenged with resources, and we're going to be challenged on the policy end. And so basically, I just really want to conclude my brief remarks by saying that, again, I so much appreciate the discussion and the ideas generated by DCBS and generated by all of the participants in doing what I think we all fundamentally have in our hearts about trying to do the best by people who are struggling here in the state of Portland.
Thank you, John. And I just would reciprocate that. I think most people in this room know, but for those who don't, you've been a long-time passionate advocate, and we appreciate your patience, your persistence, the wise counsel you've provided the legislature, DCBS, this committee, your engagement in the process. Those are not the remarks that I would have hoped you would have made, but I totally understand, and I admire the fact that you did make those remarks given the context today. So we would hope that you would stay at our table, metaphorically speaking, because we're not done yet. And,
Supposed to think he's retiring.
Well, we're not going to let him fully retire. We want to keep you engaged in this work, as we all want to be engaged in this work. And this is a one step in the process, and it's not a step that a point in time that we thought we'd ever be at, but here we are. So I don't think any of us are giving up on the challenge as you framed it so appropriately. Another comment, please.
My name is Janet Bauer. I'm a policy analyst at the Oregon Center for Public Policy, and I think I will stand because I have a soft voice. Thanks. I wanted to share that I have participated in several of the discussion processes last summer with a stakeholder group making recommendations, and then with DCBS's subgroup of your group. And I've been really pleased with the quality of the discussion, and so I have some prepared remarks on paper that I'm going to give you, but I'd like to just sort of quickly summarize what my comments are. As advocates, we have been focused on the groups that have been struggling the most, and as John has suggested, it's, you know, as we know, the data shows that low-income folks who aren't eligible for Medicaid are most likely to be uninsured. So, as our advocacy group, we are not wedded to a particular solution. We felt like Basic Health could provide some, you know, great opportunity, and we really appreciate all the investment in exploring that option. But there are technology barriers, and if there are other solutions that would work better, we're not interested in increasing the problems of churn, et cetera. Let's go for what works. Now, in terms of the study update, some of the brief takeaways are that it affirmed that this population is struggling. Only a little more than half of those in that income category are signing up for marketplace coverage. The rest are hanging out in employer plans that are unaffordable technically, or and these are the folks who are eligible for a basic health program, or are uninsured. So, and you know, as we've talked about, Basic Health could boost their coverage. It could also address the fiscal cliff, and this is something that lawmakers have brought up. Once people income out of the Oregon Health Plan, they have a lot of costs that they weren't paying before, and lawmakers have really worried that they're not making that transition, and that could be part of the problem. And so we've thought about, let's address that affordability issue. So I have also made some reflections on the hard work that the department has made in reflecting on the update study, and would urge that they would include the issue of the fiscal cliff, and a couple sections on how they portray the significance of the drop in the income. And you'll see this in my report, in my remarks. But lastly, you all had talked about the issue of disparities. And one thing that I would suggest, and I had made this comment prior, is it would be really useful to note that although basic health might increase a disparity between groups that are not able to be helped, that basic health is not making those groups any worse off. And we need to celebrate that we are accomplishing something, and we're not making creating a problem by increasing that disparity. We're just, the program is limited in being able to reach everyone in that group. So thank you so much for your deliberations, and I appreciate it. Look forward to joining you on the side and forging together a solution. And I'll go ahead and pass this around for you, and I also will provide an electronic copy to staff. So, thanks.
Janet, thank you, and also thank you. There's a ton of work that you've invested into this meeting, and we recognize that, even though we weren't all there. And we want to acknowledge you, and I want to just acknowledge not just John and Janet, but all of the advocates who for years now have been very effectively advocating for this population, and we would ask you to stay at the table with us. Again, not the discussion we were planning to have today necessarily. Yes. The environment has changed, and I appreciate you acknowledging that. But let's collectively not give up on addressing this population.
Absolutely, I accept that wholeheartedly. Thank you.
Jessica?
I would like to start by echoing and thanking John and Janet for their strong advocacy for this population. And I apologize, I'm Jessica Adamson. I'm here on behalf of Providence Health and Services, both our plan and our delivery side. We are just really grateful for the length of advocacy on behalf of this population. These are folks that we see in our clinics every day, and we insure a number of them in the individual market today. They're an important population, and we believe that in the previous slide there were bullets all the way down, and the last one was maintaining the status quo, and that, in our view, cannot be the solution here. It's just to maintain the status quo. We have to move forward in expanding access to populations that are not currently insured or who can't afford to use the insurance that they have. That is desperately important that we fix that. We as a system view folks that are below 300% of FPL as individuals who qualify for full charity care in our facilities. We recognize how important it is to bring folks in and get them insurance and make it possible for them to be able to use that insurance. That said, we cannot and would urge this committee not to support moving forward with the 1331 waiver, the BHP, as we've discussed over time. We think that the alternatives on the table or something like them as we continue to work them are a much more favorable option to serving this population, first and foremost because of the multiple points of churn. The conversations I have every day with my care management team and my medical group homes are about how much they struggle to keep people when they transition from being in our Medicaid population into commercial and then back again, and the difficulty of getting through that eligibility system and making sure that they get assigned back to their primary care provider. For those that particularly have really tough chronic conditions, making sure that we don't miss checkpoints with them just because their financial status has changed doesn't mean that their health condition has, and we need to make sure that we don't lose folks in that transition. So we would be concerned about that from just frankly a medical management standpoint. We would also, I think, very obviously the technology barriers aren't insignificant. Those concern us. And last but not least, we share the concern that was raised earlier about the 1.5% impact to the broader market being low. when we were having the dialogue with Wakely and Urban, one of the questions that we asked was whether or not that 1.5% included any assumptions around cost shifting impacts, because of the assumption that folks taking BHP patients would be willing to accept an 82% of commercial rate. It did not. So again, we view that 1.5% as being pretty low. We have real concerns about what that additional market might look like, and we have particular concerns around medical management. But we are not ready to walk away from this table. We believe we need to do more around subsidies and cost share assistance to make those transitions and access points easier. And we are ready to stay at this table as long as it takes to figure out a long-term solution. And so we would urge this committee to move forward with continuing the dialogue around other alternatives, but we would ask that pursuing a full BHP not be one of them at this point.
Jessica, before you leave, and then I'm going to ask Janet and John in a minute to come back up, but we do have just a few minutes, and I want to get ahead of ourselves, but while we're in the public comment period, have you had a chance to look at the BHP alternatives, and are there some things there that you would encourage us, if we get to the point, again, I'm jumping a bit ahead, so I understand that, and I don't want to preclude a broader discussion, but while we have you here,
sure,
any of those alternatives that you would like to see us in particular explore?
We haven't had a full opportunity to review all of them, and so I apologize. I can't be here to give you a full set, but certainly looking at things that would keep people in a single risk pool, we think that's pretty important. We think it's really helpful to look at broad assistance that enables folks to continue to have choice and options. Again, additional subsidy programs that kind of wrap around the strongman that puts up. There's a lot there that I like. I have not been able to fully vet that with my folks to be able to say we are fully on board with that. But I can tell you that in the initial conversations that we've had about we've got to keep doing more, particularly with our partners that have direct line of connection to many of these populations, that these are the kinds of things that we've been talking about. And so we'd be very, very excited about continuing that dialogue and that work.
Thank you. And with that, let me just ask, are there others that haven't commented? Otherwise, I would, John and Janet, if you're so inclined, we have time if you'd like to respond to that same question.
Yes, I just want to say that I'm really pleased about the discussion that DCBS put forward about Medicare. I got my Medicare card last week. But unlike some of the people that struggle with Medicare, I won't have the same kind of affordability issues. Again, I'm very grateful for that. I would say if there is anything like a 1331 or 1332 waiver process left in the near future, I have my serious doubts that we will. However, want to return to that last principle of our values, and that's innovation, and it's going to be incumbent on the state and all of us together to work on the kind of innovation that we're going to need, and that's going to be a resource discussion, quite frankly. So I'm happy to engage for the remainder of my time to the end of December to engage in a discussion about where we go from here. But I appreciate the idea that we can look at things that are innovative and maybe are home-based here as far as Oregon is concerned.
Thank you.
Thank you so much for inviting further comment on it. Today's the first day that I have seen this, although some of these ideas have been kind of circulating. I think this has real promise. One of the principles that we had discussed last year when we were making recommendations about a solution was that whatever it was we were going to do would build on the progress that Oregon is making in improving the bang for the buck, the quality of care, being more efficient with the care that we're doing. So our vision was that Basic Health would conform with Oregon's coordinated care model. Now, when we're contemplating investing state dollars, public money, in a subsidy product, I think it makes a lot of sense to be thinking about expectations for moving further down the road on this in the commercial market, so that we are forging ahead with improving the delivery of care, keeping people healthy, and so that would be one of the trade-offs that I would recommend, is that there be some similar accountability that coordinated care organizations have, that we include that in this for this population if we're going to be doing these subsidies. Thank you.
Excellent. Please, come on up.
Hi, Joseph Santos Lyons. I'm at the Asian Pacific American of Oregon, or APANA. And mostly wanted to sort of respond to the comment, actually both sort of 2 points. Well, first, in our communities, too many folks are still uninsured, and they face the 5-year bar barrier and would normally be able to get Medicaid. And our populations are struggling to be here, despite whatever the current environment is or the lack of a solution. But secondly, and more importantly to this, I appreciate the commitment to dialogue and to the engagement. And I'll say that our groups have been at the table for 8 years, and no one else is bringing these issues up consistently, and that's a problem. I mean, we need the healthcare industry, we need government to be actually helping to lead this conversation. And we come to this with only the capacity that we can raise from our communities. And it's not as much as the big, I think, healthcare industries and the resources that come from our tax dollars. So as a taxpayer, as someone who grew up here in Oregon, and who sees this impact in our families, we need to see leadership, not just, let's talk about it later. And we'd like to see it from the healthcare industry, from the governor's office, from DCBS, from OHA. Because the work we've done now may be on pause for a while, but at some point on the horizon, we want to see a solution. And we can't just sort of be in a situation where it's sort of platitudes and not action. So really do appreciate the space. I really want to appreciate especially Oliver and Deanne for really, really hard work on the issues, and appreciate John and the coalition for sort of coming together. But also just ask yourselves, particularly those who have resources and capacity, who is going to be speaking for these communities when we can't be at the table all the time? Thanks.
Joseph. Other public comment? Would people want to just head right into the committee discussion? Does that feel appropriate? Oops, nodding heads. So again, just to frame this, we need to come up with a formal recommendation back to the legislature. I'd like to have a little discussion first, maybe some questions, and then at the appropriate time we can go to a motion. Sean, one of the things I wanted to ask you to do, if you're comfortable, is just following up on Joseph's last comment. There is a private sector premium assistance program that is functioning roughly similar to the BHP alternative.
And the COPA bill, that'd be the same.
So would you mind just talking about that briefly?
Sure. So
not everybody has to be aware of that.
Currently, the IT structure doesn't permit any enrollment in a program that Oregon sets up, but we use a wraparound model where we would pay down the premiums that are left over after the tax credits are applied. So that's the same structure that the COPA model is using, where you enroll, in COPA's case, First and Calum, but you enroll in a QHT through the federal marketplace, get the tax credits, and then you would apply to the COPA Premium Assistance Program, or Project Access Now runs their own Premium Assistance Program, and then we pay the remaining premiums, and then each program has a way to address the remaining out-of-pocket costs. So it sounds like what we're suggesting is something along the lines of that, where we would expand to a larger population, whether that's 200 or 200%, or all of the people barred by the 5-year bar, in order to leverage the existing QHP financing structure, which hopefully tax credits survive, but which would allow us to continue that in the future. And the advantage of this is that it gives us a way to implement this potentially sooner without having to move an IT structure through first. So there's less moving parts. We can let the federal government, as long as those tax credits considered to exist, this would be a way to potentially cover these same populations that BHP would. It would still not do anything about the family budget because we are barred by the tax credit structure, but that would be a way to increase the same affordability and equitability for populations that are for Medicaid. So it seems like that's the idea that is being proposed in this VHB alternative, is something along those lines.
And of course, thank you, that's helpful. Of course, the obvious limit to that is you can only extend that assistance in the case of the Project Access Now program to as many people as you have money for.
Mm-hmm.
And so operationally, it seems to be working well. The limit is funding.
Yep.
How many people did you touch?
We had 215 on last year. We're expecting somewhere in the range of 500 this year. Then we're also working closely with the COFA program, which would see about, they're expecting 800 roughly for first year enrollment, something.
And Sean, is the assistance only available for a silver plan?
Yes, we limit it to silver plans because we're looking to get people into care, but that's the similar structure for the COFA program. They have 6 plans that they use. We have any silver plan, but the goal is to get people into care that they will use and start affecting those cost drivers and the actual health access, as opposed to just paying for someone's insurance that wouldn't necessarily get used ever. Because they often will still face the deductibles or something like that. We have a waiver program that can work around some of that, but
I mean, the reason that a consumer in that category would pick a bronze plan was because it had a lower premium, but Project Access Now is paying premium, so there's actually no reason for them to.
So they would just have the out-of-pocket costs, which are already lowered, and we're trying to get them in for usable care.
So we're still technically in the public comment period, so I want to ask if you have a comment.
Sure.
Please go ahead.
For the record, Christina Ryan with the Speaker Coach's office. Just a point of clarification on services that Project Access Now offers.
Mm-hmm.
My understanding is that it's premium assistance support only. So my understanding of the basic health plan is that it also reduces cost sharing. That's a significant burden.
Ours is not only premium support. We have a waiver card that we work with connections with all the hospital systems and clinics. So anyone who recognizes our waiver card, which is within the majority of each of the network of major carriers, we have to get those costs waived. Any client that gets a bill over $30 can also contact us to get assistance and potentially getting that waived on a case-by-case basis. So we have ways to address those things outside of that. The COFA program uses a reimbursement model, so there are many ways we could potentially structure the out-of-pocket cost part of that. But
And the other 2 points of clarification, albeit more so probably for me than anyone else in this room, can you speak to the network that Project Access Now serves and how you are funded?
we are funded by all the local hospitals in the area, so our program is limited to the Tri-County area, which is just on the funding consideration. Is there more depth you want me to go into on that?
Yeah.
Okay.
So I think the theory is that if you are between 138 and 200 of the FPL, and you're eligible for the premium assistance program through Project Access Now, you're going to go into that, and then you're also under all of the hospitals in the metro area, you're eligible for their traditional charity care policy, so which for most hospitals goes up well above 200. So the idea is that we're using the charity care policy to fill the cost-sharing gap. We're using the premium assistance program to fill the premium subsidy gap, and then we're putting folks onto the marketplace and leveraging those federal dollars.
And the waiver I'm referring to is the charity care, that is where that funding comes from.
And I promise this is the last.
No.
What is the size of the current population served by Project Access Now?
The premium assistance program specifically is 215 people last year, and then we're going up to 500 or so this year is our best estimate. We are rough targeting on that. So
Great, thanks.
you don't have it.
Some other communities have tried this, and I know Clark County is looking at starting one. I've shown that in the,
They already have one that's smaller than ours, about 100 people, I think.
yeah.
Another question about the program. I know that there was some question in the early days of setting this up whether all of the carriers would accept the payments from Project Access Now. What's the status of that?
Each carrier has its own procedure. We have to physically deliver individual checks to some of them. It really depends on each carrier. There's no standardized procedure, but we've been able to build up those relationships and work with that. So that's been a pretty intensive process, but that has been successful this time.
But none of them are refusing to take the payments?
We don't have contracts with every carrier, but the ones that we have worked with have all gone well. So we have most of the major ones.
The fact that they're not directly a provider helps that.
Right.
So
Please.
can I add one more public comment?
Yes.
I'm Victoria Dempsey,
Oregon Primary Care Association. And we've also been working on this and actually have a similar starting point for our work on this from 2013, where OPCA ran House Bill 2132, which investigated responses to churn to diminish churn between people in the marketplace. So basic health plan and other kind of wraparound and enabling programs were some of the options that were reviewed by the Medicaid Advisory Committee in 2013-2014. Initially, the basic health plan was seen as moving the cliff to 200% FPL, but we do see that as far as we move it away from the 139 or wherever the Medicaid cliff is, the more financially able a household is to deal with the financial cliff. So one of the things, there are just two goals I want to bring up for us, which is kind of, we want to somehow build a network that works across the state. One of the things that we've learned from the Urban Institute Weekly Study is that a lot of the folks who are unable or who have difficulty affording their marketplace plans don't just live in the Florida metro area. Right. So as far as we can expand these programs to go beyond the metro area, we really see that need. And since our network is kind of not just through the metropolitan areas of Oregon, but also serve rural and other underserved communities, we know that we're running into a lot of folks who are persistently uninsured or underinsured. And CBHP and other solutions or wraparound solutions like that as being a necessary way to support families and their economic status. And the second thing is, as we've talked about this, we've thought about how we can well use state resources, whether that means the coordinated care model, some kind of value-based pay, or making sure that we stretch these dollars as much as possible. So if I can toss in, these are kind of some other jargony issues, but they're being considered by other folks, other groups under OHA, but the value-based pay conversation that's happening under the Oregon Health Policy Board regarding CPC Plus and other ways of moving toward value-based pay, if there's a way that we can make sure that this is a criteria as well for the plans that these kind of enabling service dollars are used, so we can make sure that we enhance the value and stretch those dollars as far as we can. OPC would be really happy to see that. We do know that we have very scarce, that we might be entering an atmosphere of scarcity, or at least a sense of scarcity.
That last point in particular is a good call out, thank you. We have had some early conversations with the Health Policy Board, but not around that, so that's a great potential discussion point for us if we move forward. So
and CPC Plus, that kind of coordinated value-based pay conversation, just to note that they're looking at ways to expand some of the criteria for CPC Plus, because right now it's only around Medicare and providers that serve Medicare. So pediatric practices, federally qualified health centers, and rural health centers are all exempted from that kind of CPC Plus value-based care model. So if we can find a way to segue this with that conversation on how we can expand that model into other providers and other clinic types, that would be really great.
Excellent, thank you. Claire, anything to add to that? Or is that...
That's why she's our policy.
Yeah. Okay, so let's return to the committee discussion. And, oh, sorry. Get it.
We've had a lot of discussion about dental health, and the study costed out inclusion of dental services. This is something, as we know, that very few people who are in QHPs who are low income have access to. It would be really important to us to keep the idea of including, trying to find a way that we can include dental coverage for this population in a subsidized manner. I think it would be an impetus and a carrot to encourage those last folks, particularly young people, to get engaged with our system. Thank you.
Janet. Jesse, put you on the spot. What's your reaction to the presentation, public comments, and the discussion we had?
Happy to be put on the spot. So first of all, I think if this wasn't totally clear in terms of framing the discussion, I I think it's really important that we come out of this with a specific yes or no recommendation on the basic health plan to the legislature, not some sort of kick the can down the road recommendation. But I do think that we can, if we decide that the recommendation should be no, then it doesn't have to just be no, and this is the end of the conversation and the end of all hope to meet the needs of these populations. I think we can commit to continuing conversation and looking into the policy options that the end has put together, some of the policy options with a 52 waiver, which may or may not continue to be an option. And I take Joseph's point that more talk is not enough very seriously, and I hope that we can come out of this with a real commitment to doing something in this area, and a recommendation not just that we continue the conversation, but that we actually, at some point, do something about it. And what we're going to be able to do about it is not going to be clear for a while yet, probably, but we do need, I think, to make a commitment that we are going to actually do something. That's all preface to my own feeling, which is maybe a motion, that our recommendation should, in fact, be no, because I think, aside from the merits of basic health in a vacuum, I just think there's no chance that a waiver would actually be approved, and I don't think there's any reason to recommend to the legislature that we go down that road. And even if the outcome of the election had been different, I think that there are some really serious operational concerns about how this would work that I would want to have better answers to than we do now in order to make a yes recommendation. So my motion, this is not very wordy, but my motion would be that our recommendation on the basic health plan to the legislature be no, but that we make a very firm commitment to continue this conversation and come out, I don't know, this doesn't have to be, we don't have to tie ourselves down to a specific number here, but maybe middle of next year with a more specific commitment about what we're going to do to address the needs of these populations.
Thank you, Jesse. One of the things I thought that worked well in Pendleton on the technology discussion we had, which remember there was people on both sides, was we really made sure that everybody had a chance to talk. And so I'm going to encourage everybody here in whatever order, whatever length, and certainly not compelled, but I am going to at least ask you to say that you don't want to weigh in. So let me just ask who would like to respond to Jesse's motion or con. Before we become real formal about it, I want to make sure everybody has a chance to weigh in.
That's a no to like any of these options.
No, just a no to the basic health.
Just to the 1331 waiver.
Yes. Okay. I think we should continue talking about all of the other options and probably think in a broader way about whether there are any other options that aren't on the list.
Dan?
Ken?
I actually agree with Jesse right across the board. It's amazing. The specific proposal I'm concerned about some of the operational aspects. I am concerned about the impact on separating out the risk pool and creating separate risk pools and so forth. And then we're facing a pretty significant state budget situation. And another thing that requires, even in state budget terms, looks like a small amount. I think it's going to be a big deal in this environment. I do think it's important that we commit to something that moves the discussion forward to address this population. And one thought I had, Sean, I think what you guys are doing is great. I don't know if that's scalable in that form. I mean, going from a few hundred to many thousands. A manual system, I'm pretty sure it won't work there. I mean, we need something robust. I actually was thinking, and I wouldn't apply that term to this problem, but whether there's a possibility to integrate something within the carrier of last resort proposal, whether there's some way to look at that solution and bring something that applies to this population as part of that. Again, without trying not to separate out pools, risk pools, and that's one have to think about how to do that. But I think there might be something there that could be a solution that might be able to deal with a couple of things. So I agree that we should not go forward with the basic health plan as proposed, but we should really commit. And I would hope we'd leave here with a commitment to process as to how we go down that road to put something greater together.
Thank you.
All right, I'll jump in.
Yeah, please.
I see you looking at me.
Well, you had a very thoughtful look.
Well, because I have gone back and forth on this, I actually see the people that can use this. I am involved with certain communities that could really benefit. And with that being said, I would say no to the BHP. It's going to cost enough money in a bad budget situation, which I'm very sensitive to as well in the state. I like the idea of the hybrid.
Say more about that.
Well, it kind of comes off of what Ken was saying. I think we have to go forward with working with this population. I like the BHP-like alternative, and I think that could be adapted a little bit more. There's not enough information about costs, of course. So, but I liked it as a starting point for making, for maybe crafting something that is going to be less technologically heavy, less dependent on making some of the changes with the federal government, and more compacted within our own state. That's what I think.
Thank you. Cindy?
I would agree, and partly from the standpoint of I think we have to be very, very focused on not doing anything to undermine the individual market in the QHP. And to me, this kind of digs out some underpinnings, and I think everybody should be covered. I would love to look at subsidies. I'd love to look at the resources of the state in terms of personnel. I think unless we get to the healthcare cost piece, I'm not sure we get anywhere. And so are there other resources to make use of other than money to serve populations?
Was that a yes or a no?
I vote no against pursuing the BHP as not the alternative, because I think we have to get the population served, but not carving out of the QHP.
Yeah. And I'm taking notes so that I understand kind of people's general concerns, and we'll collate those together. But one of the things, Pat and Barry, I think we want to be able to do is really communicate back, not just a yes or a no, but to be very clear about what the concerns were and what the energy is around alternatives. And I think we're getting a very good sense of that. So that's why we're being sort of methodical and drawing out some specifics of what you like and don't like. That'll allow us to be more effective as we communicate back to the legislature, the governor's office. Shannon?
Yeah, I think I would agree with what's been said so far. I get to see the customers firsthand, though, and see what an impact it has on their lives. And see people going from Oregon Health Plan into the QHP market and have to struggle between a plan and medication and accessing doctors and being really, really concerned about that. So I would say no at this time, but like that time frame on when we revisit this to be able to help that population, because there is such a huge need there.
Thank you.
Okay, so in the first place, I would vote no on what we have here now before us, primarily on the technology issue. And plus, I like the idea of examining further some of the alternatives. But the other thing I think about longer term, after we had that discussion, which I participated in remotely when you were all in Eastern Oregon, I actually applied to the department to get the full report on all of the IT companies that had submitted the RFPs, and there were some that were all 10s. They were excellent. So that's one thing. The second thing is I'm anticipating that healthcare.gov may not be available, and that we need to think broadly about how we're going to continue to provide. And I think what that's going to mean is we're going to need to look at our own IT. And the third thing is the income provided if we have our own IT will help us finance whatever we come up with a basic health plan. Whereas otherwise we'd have to go to the general fund for that, and that's going to be crazy. So that's, I don't know all the details to it, but that's my broad perspective on how we can save the marketplace and launch a BHP type program.
Good. Thank you. Yeah. So that would be down the road, obviously, but that's what you're saying is let's think about the confluence potentially of those two
Think big
objectives.
and how to make all the parts of the puzzle work.
Fit together. Yeah. Absolutely. We have some folks on the phone, but we also have Joe, and I want to make sure Sean and others to weigh in. So Maria and Joe Finkbonner, if you guys get ready, if you're on, get off mute, but I want to give you guys a chance.
Yes. So I think I share a lot of the same concerns that this committee has voiced and shared, but I see it in a different way too. Rather than no, let's work on it, I say yes, but with more focused attention to editing, and because I think there's value in a lot of the work that has been done to come up to this point where there's actually an alternative that's set forth. So I would say yes, they'll work hard on editing and addressing a lot of the concerns that are there. I tip more to, I speak from, as a COFA person, as a person who's included in the population that we are addressing right now. I'm also a pastor, and this Friday is a funeral that I am going to be performed for a person who is my age, has been dealing with a lot of health issues, compounded over the 20 years that COFA citizens have not had any solution, any option for health care. So even to say that I will, maybe down the road have an alternative, to me is a life and death situation, because there are people who are dying, and I'm burying too many people. And so the urgency is much, much more than just wanting to address the specifics of the system. It is also saying we have to have something in place for people who may not survive the next day. So I come with that perspective as well and say, yes, but work hard on addressing all the concerns that we have. Thank you.
Thank you, and thank you for being willing to put that out there. Appreciate that.
I'd definitely follow up on Joe's point that getting something for these people as soon as we can is incredibly important, and I feel like a lot of the IT problems and other structural issues with BHP means it might not be the fastest thing to actually implement, even if we tried to move forward with it, because the IT piece would be the 2019 at the earliest that we could implement that, and then that puts it out past 2020 when we'd see a basic health plan go into effect. If there's something we can do quicker than that, we should be examining that as well. My biggest concern with the basic health plan as a whole, even if the IT could be resolved, would be just the exponential increase in complexity to navigate the system. The QHP and OHP already use different structures to calculate family size. Pregnancies are counted for OHP, so there's situations where you could be qualified for all three. Each system would determine you as eligible for that three. You don't know where that tax credit would be supposed to be recouped. That concerns me, that because that complexity of our health insurance system as it stands is already a significant barrier for people using their health insurance, to getting onto it. People just throw up their hands and don't want to deal with it because it's so much of a new language to learn for them. And I don't feel like BHP is quite getting across that, addressing that issue, and that there are alternatives that we might be able to look into. And I just wanted to follow up on the point that we do have COFA to look at and see how these solutions work. They may have a more expandable building process. You might be more qualified to speak on that than I am. But.
So in terms of the COFA Premium Assistance Program, one of the things that we were able to look at with the carriers is that they are able to contract with the marketplace. It is part of their obligation to participate in the marketplace. We have a COFA Premium Assistance Program as part of the 2017 contract, so there is a protection for both the marketplace and the carriers. One other feature that this program has is we only use a standard silver level plan with 94% AB, which provides, I've seen some enrollment, proofs of enrollment rate where folks only have to pay $3 in monthly premiums, so after tax credit. So all these things put together make for a very good benefit for the consumers. In terms of billing, we have set up a monthly, we are going to have a monthly workflow with carriers through ACH transactions. This allows us, especially during open enrollment, to turn around premium payments because policies are not active until they are effectuated. And we have committed to pay these monthly premiums, and we will be aggregating our premiums and sending it to the carriers through a monthly exchange.
Thank you.
So we're my comment.
Thank you. Claire? I didn't mean to bypass you.
No, that's all right. So echoing the concerns about having 3 options and all the future issues, definitely. I've also been thinking about the IT system, and it's hard to think about that without thinking about what might be not available, perhaps soon, that being a federally facilitated marketplace. And maybe initially we can think about options. I mean, I am a yes for doing something. I like to frame it that way, not a no to basic health plan, but yes to some sort of wraparound system, using the current technology, but hopefully actually planning for the future technology that we might need to use. We have built the state Medicaid system enrollment. I know it is not built with any of the provisions for the marketplace, but that might be what we're left with soon. So what could we do with that platform? So I think maybe it's time to think about what we can do using that platform to accomplish this and a lot of other things that the marketplace is going to need.
Thank you. Maria and Joe Finkbonner, and I don't know if Mark Fairbanks has joined us, but we want to open the telephones now and invite your comments.
It looks like Maria dropped off and didn't come back.
Maria dropped off.
Oh, I'm here. I'm here.
Oh, you're here. Okay. All right. Maria, do you have some? Have you been able to follow our conversation?
I have been, yeah, and I share the concerns and opinions of some of the other things that people have talked about, and I see the need there. I have that direct client enrollment experience, and I know there's a need, and I would love for us to be able to meet it at the moment, but I think there's other things that we have to consider. There's things up in the air, so my vote would have to be for not right now.
Okay, and any concerns? We've heard concerns about cost, about technology, about system and consumer complexity.
All of especially that consumer complexity. I do think right now, with the existing problems that the Oregon Health Plan has had, I know for us in this area, it took us a long time just to be able to use their current system, and consumers get a ton of mail already, and just a lot of different confusing messages. So I think throwing in another option would add to that. The technology also concerns me. I echo the healthcare.gov, not knowing if that's going to be there in the near future possibly. So I think all of those things we have to take into consideration.
I don't know why everybody keeps raising technology concerns, but okay, lame humor. I know we have to laugh about it at some point. Joe, are you still on the line?
I am still here. Can you hear me?
Yeah, we can.
Okay. Yeah, I appreciate all the concerns that have been expressed, and I'm sensitive to those. In addition to that, I want to raise the concerns of making sure that we have an Indian health system also that's in effect within the state of Oregon that comprises 9 tribes that are vital in terms of delivering health care to tribal members that live in many of the counties in the state of Oregon, and that whatever decision we make works to integrate within those systems as well and not exclude those populations from either enrollment or the health systems as providers, so that tribes can be reimbursed should they deliver health care to those people that are enrolled in whatever insurance marketplace we create.
Thank you, Joe. Mark, did you happen to jump on? Okay.
Dan, can I offer just an operational detail that might help add a little bit of information to Jesse's kind of the second half of his motion, which is that he wants to be really intentional about how we talk about going forward and creating a space to talk about these issues. We were going to ask at the end of this meeting for people to volunteer to serve on the 1332 or the waiver process, this kind of part 2 of the BHP process. And I guess I don't see why that wouldn't be a space to continue this discussion, even if it's not a waiverable or if we don't need a waiver for certain issues, even if people are uncertain about the future. It seems like that would be a good, really, way to approach this conversation and kind of keep everybody accountable for continuing to have it. So I don't know if that's helpful or not.
That's very helpful. And the only thing, and I'm going to sort of transition it back to Jesse for a formal motion, the only thing we might do is actually put a timeline on that. I heard March thrown out.
There is a report back to the legislature due in March related to waivers, of course. But if you wanted to add an additional time frame related to just a larger conversation, you could do that.
I guess I don't want it to be open-ended, and I'm hearing some consensus on that. I'm also hearing, we certainly have the COFA program underway. We have a private sector premium assistance program that I think there's some learnings from. And so I think we have, in addition to the work that Deanna and the team have put in here, Oliver and others, we have a robust set of policy options. And I like the idea of moving ahead aggressively to dig in and frame those and be very affirmative as we get back to the legislature about, maybe fleshing those out, prioritizing those, however that subgroup wants to handle that. So with all of that, Jesse, let me toss it back to you.
Before I make a formal motion, just a question in terms of having a formal timeline, which I want to be part of this. March is when we report to the legislature on
waivers.
On 1332 as well.
The BHP alternatives. Thank you. I mean, BHP is actually December, but then March is kind of everything else. Yeah.
So, I mean, we obviously need to do that because it's a commitment to the legislature. But I'm not. I don't by any means want this to come across as delaying or slowing down the conversation, but I'm not sure that March is early enough that we will have a sense of what's happening at the federal level to make a recommendation on this. So I would suggest that we push it back at least a couple of months, maybe until
perhaps an interim report in March. I think you're exactly right. I was going to make the comment that I kicked this off talking about take a breath, but that's not the same thing as hold our breath, right? Because I do think it's going to take some time. You're exactly right to figure out if this is really inherently about how do we fill gaps in the system. What are the gaps? Because I think whatever happens, it's certain that the gaps are going to change and potentially profoundly, and it would be difficult to go off and try to design gap fillers without really knowing what those gaps are.
Yeah. Okay, so interim report in March, and then I'm going to say, unless anybody has a strong objection to this, that we come up with a final recommendation by, let's say, July 1st.
On that second piece.
Yeah.
Yeah.
And that we make as firm a commitment as we can without having done the work that the recommendation will not be do nothing. Obviously, we can't make a totally firm commitment to that until we do the work, but I am very strongly committed to figuring out a solution here.
So
formal motion. I move that we recommend to the legislature that they do not move forward with a 1331 BHP waiver at this time, but that we continue the work group conversations around alternatives, including 1332 waivers and possible non-waiver alternatives. That we have a work group that meets as a subgroup of this committee that provides an interim report to the legislature in March and a final report with recommendations by July 1st.
Do I have a second for that motion?
I just have a quick question.
Let me have him second it first, then the motion be on the table.
I'll second.
Second the motion. Okay, discussion.
Okay, sorry. Just with respect to timing. So if there's a cost variable in there, is that July 1st recommendation to go forward really doesn't happen before the next biennium?
Right. No, that's not quite true. It could certainly come in the February short session following, which is budget-oriented session. It's too late for consideration as part of the budget process right now, anyway.
Right. I'm just trying to get a sense of. We're not trying to push it off, but effectively do for how long?
Yeah, pushing it off for 1 year, not 2. It's also not totally inconceivable that some pieces of it could be done administratively.
Point of information for the group that was brought up by one of the participants is that the end of 2018, the 5-year CCO contracts end. And so to go forward with any kind of hybrid, which there's been a lot of interest actually in broader marketplace, not just people below 200% of the LPL, that could be a fortunate kind of timing to be able to add that as an option for some organizations, basically.
Sorry, I didn't cut you off.
Oh, no, that's
So we have a motion on the table, additional comments, discussion on that.
Are you saying that even if we were to say go ahead with the BHP waiver, that in the budget process we're already...
I should be a little clearer on that. The agency budget process is done. If you were to say go ahead and come back with that in December, the legislature would need to add that basically on its own motion to the budget discussions that are going on. But you'd need to do that by December. Anything that you come back with really later in the session, it would even be really, nothing's impossible until sine die, but it would be very difficult.
Other questions, comments? I really don't want to cut off comment, but I feel like we've had a good discussion. Oliver, point of order back there.
One, I know not part of the discussion, but I do want to say I know Mark Thursday, Florida Health Authority, not here. Oliver Doctor, Florida Health Authority. I would turn this really, I think, Jesse, Dan, to you. I think there's parallel conversations going on with the Health Policy Board, and it seems like at some point we need to intersect the conversations going on with this committee, with the Health Policy Board, to really have a larger group think conversation about whatever happens at the federal level, Oregon looking at Oregon solutions. So I would just encourage this committee to think about reaching out to the Health Policy Board and having those conversations together simultaneously.
Thank you.
And we have a subset of us have had some conversations with the Health Policy Board leadership about having a joint meeting at some point. And certainly we talk to each other informally anyway, but I think that would be really helpful at some point.
Okay. We're at time. Are you okay with a voice vote if we do it that way rather than a roll call vote? So Jesse has a motion on the table. As best I can restate it, it's to provide the formal recommendation back to the legislature not to proceed with the 1331 Basic Health Plan waiver, but that we will nominate a subcommittee of this group to flesh out and make a series of recommendations around BHP alternatives, both in the report, the staff report, and those raised here today, with an interim report in March and a final report by July 1st. All those in favor of that motion, please say aye.
Aye.
All those opposed? Motion passes.
Could I make a couple of brief comments? First of all, thank you for that. I know the legislature was really looking to this group for a conclusive recommendation, and so I really appreciate the fact that you guys did the hard work along with everybody involved in the stakeholder process to do that. Second, picking up on Ken's suggestion, I certainly think as we look at the carrier of last resort concept, we can certainly look at that as we think what a design might be and try to see if there's a way to incorporate elements of this in that on kind of the timeline we've been talking about. The last thing I just wanted to comment briefly on about the future of healthcare.gov. That certainly is one of the most critical questions out there. I think you have to think of the future of healthcare.gov as a platform deeply wrapped up with the existence of tax credits and cost sharing. If I don't think one or the other goes away. I think they both go away. There's obvious bad news with that. The one piece of good news is that it makes a platform a lot easier to think about because it's not an eligibility platform, it's a shopping platform. So part of what we're going to be doing as we don't hold our breath is begin thinking about what are our contingency plans for what that world might look like and what else might change, but what would be platform options for whatever kind of a structure we might have that would be left. But it would likely be profoundly different because it would be a non-tax credit world.
So to that end, Barry, when is our next meeting, and what can we anticipate?
Yeah, our next meeting is at the end of January, and I think we talked formally about bringing the pregnancy SEP issue back for another discussion, and also by then we should have some really good open enrollment information that we'll really be excited to share and probably really dive deep into that, and then do subcommittee updates and any other updates that we have about the work we're doing.
And we don't want to wait until January to get the subcommittee and Jesse's motion going. So should people reach out to you, and I could pick some people that we are going to ask them.
That would be great, and I can also send out an email reminder, so whatever works best for this group.
We've already named Jesse's subcommittee, so.
Can
I will commit to participating in this.
Yeah.
Barry, do you have any sense, just early activity of an enrollment?
Dawn and I were just on a call with CMS at noon, and they said that they won't tell us until after November 11th what our enrollment numbers are, but they said the first week was record enrollment for every state. So that's some great news. And they were getting a lot of questions on various hotlines throughout the country about, will I still have this insurance? Should I even bother? So we're just really prioritizing on keeping our staff focused on making sure we're still getting folks enrolled.
Laura?
I know I'm not a member of a committee, but just as you're talking about your meeting again at the end of January, going back to the conversation about the matrix of ideas, it would be really ideal if we didn't wait until the end of January to hear if you have feedback on those. So I just want to reach out to us sooner. I mean, I'd say ideally in the next couple of weeks as you think about this, because I think we're wanting to try to get this crystallized a little bit more in December.
And we don't have commented on the legislative process, obviously, but the goal is to get some generally consensus. We don't want to pursue things that are going to be DOA.
And I mean, as you can see, there's a lot of complexity here, and then there's a lot of, I'd say things kind of developing that we're going to have to, I'd say, be kind of reacting to a little along the way. And so I think the sooner we have kind of some of the thoughts about good things, bad things, unintended consequences, then it's we can be better prepared. So that'd be great. So email us, call us.
Thank you, Laura. Okay, I think with that, and we'll certainly